Good morning, everyone. My name is Elizabeth Soto Cardona. I am the Director of Center Operations of the SVM Center. We would like to welcome you all to Hospital for Special Surgery. Thank you for making the time to join us this morning. We will be starting. I will start by welcoming Dr. Robert Spira, the Director of the Scleroderma, Vasculitis, and Myositis, Center. Thank you.
Okay, good morning, and really thank you for being here on a Saturday, and I especially want to thank some of the volunteers really who made this work for the Scleroderma Foundation, and also for Elizabeth for the time she put in on this, but really mostly, our speakers who are giving up soccer and all kinds of things like that with their kids this morning to be here. We do all really feel that education and understanding what's going on in the broader universe is really important to success in, co-managing, scleroderma with our patients. So like this commitment to being here, to learning what's new from really some of the best and brightest, and I would say rising stars, but they're already stars, so they're not rising stars anymore. Hearing a little bit about some of the things that are going on out there in terms of trials, ways to approach the disease, or ways to manage certain complications like Raynaud's, I hope will be rewarding. The first speaker that I'm going to introduce is Elana Bernstein. I actually have little bios here, but I actually really know Elana's bio. She was like a star resident. I think she trained at the Mass General, then came here for fellowship, and then went on to establish a very successful scleroderma program at Columbia. I did not know you had an endowed chair, the Florence Irving Associate Professor of Medicine. And she's become not just a really excellent clinician, but she's also a clinical investigator and somebody who's really involved in observational studies to better understand scleroderma in general, and a real focus on lung involvement in scleroderma. She has NIH funding, which is very hard to come by these days, to help study these things, and her insights are really going to move the field forward. So I'm going to introduce Elana Bernstein, who will be speaking about ILD, interstitial lung disease screening, treatment, and trials, and she's going to talk a little bit about CAR T therapy in scleroderma as well. Elana?
Thank you, Rob, for that very kind introduction, and I'm delighted to be here. Slides are there. Right. So here are my disclosures, and just so you know, I'll be using the terms scleroderma, systemic sclerosis, and SSC, the abbreviation for systemic sclerosis, sort of interchangeably throughout the talk. So during today's talk, I'll discuss screening for interstitial lung disease, or ILD, in systemic sclerosis. Then I'll review the data behind the current treatments of SSc-ILD. And then finally, I'll present some ongoing clinical trials and emerging data in SSc-ILD. So ILD affects over 50% of people with systemic sclerosis. And people who have the SCL70 antibody, or anti-topoisomerase 1 antibody, are at an increased risk for the development of ILD. Now, nonspecific interstitial pneumonia, or NSIP, is the most common radiographic pattern that we see in people with systemic sclerosis. So here are a couple of examples, and you can see, ground glass opacities on both sides of the lungs in the lower lobes, and here you can see marked traction bronchiectasis. And these ground glass opacities are very typical of an NSIP pattern. Here's an example of usual interstitial pneumonia, or UIP, and this pattern is much less commonly seen in people with systemic sclerosis. It's the characteristic pattern that we see in another condition called idiopathic pulmonary fibrosis, or IPF. And really the hallmark of UIP are these honeycomb cysts that you see throughout the lung. So let's discuss screening for ILD. Now, everyone in this room who has systemic sclerosis has probably undergone pulmonary function tests, or PFTs, at some point. Three of the main parameters that we look at in the PFTs are the forced vital capacity, or FVC, the total lung capacity, or TLC, and diffusion capacity for carbon monoxide, or DLCO. Now, FVC basically is a measure of the amount of air exhaled forcefully and quickly after maximal inhalation. The total lung capacity is the total volume of the lungs when filled with as much air as possible. And the DLCO is a measure of the ability of the lungs to transfer gas into the blood. Now, the normal value of these different parameters is greater than or equal to 80% of the predicted value based on your age, sex, and height. It's important to monitor the trend in these values over time. Pulmonary function tests can actually be in the normal range, even when someone has interstitial lung disease. So it's really important to get a chest CT scan as well. So most people with systemic sclerosis in this room have probably also undergone a chest CT scan at some point during their course of scleroderma. Basically, a chest CT uses X-ray and computer technology to make detailed images of your internal organs. It's non-invasive and safe. It's not enclosed like an MRI. There's no IV contrast or dye that's used when looking for interstitial lung disease. And patients are given specific breath holding instructions. So you'll be asked to take a deep breath in and hold it. You'll be asked to breathe out and hold it as well. And high resolution chest CT, or HRCT, is the gold standard test to diagnose interstitial lung disease. Now, although PFTs are an important component of the pulmonary evaluation in patients with SSC, they're not a sufficient screening test for SSC-ILD because studies have shown that they have poor sensitivity for the detection of ILD in people with systemic sclerosis. So for example, in this cross-sectional study of 102 scleroderma patients with a median disease duration of 6 years, a forced vital capacity less than 80% predicted only had a sensitivity of 37.5% for the diagnosis of ILD on HRCT. Moreover, the combination of FVC less than 80% or DLCO less than 70% only improved the sensitivity to 59%. But how do PFTs perform in patients with early diffuse cutaneous systemic sclerosis, arguably those at greatest risk for the development of ILD? We sought to answer this question using data from the Prospective Registry of Early Systemic Sclerosis, or PRESS. PRESS is a multi-center prospective cohort study of adults with early diffuse cutaneous systemic sclerosis who meet the ACR-EULAR 2013 classification criteria for scleroderma. Early disease in this cohort was defined as a disease duration less than 2 years from onset of the first non-Raynaud symptom. Enrollment began in April of 2012, and participants were recruited from 12 centers in the United States, including Columbia and including HSS. So 283 participants were enrolled in PRESS from April 2012 to January 2019. 212 participants underwent spirometry, which basically means FVC testing, and HRCT, and had available HRCT interpretations and were therefore included in this particular study. So the mean age was 51.7 years. The majority were female and white. Approximately 40% were ever smokers. The disease duration was only 1.2 years from onset of the first non-Raynaud symptom. 32% had that anti-SCL70 antibody. And the average FVC, FEV1, which stands for the forced expiratory volume in 1 second, and total lung capacity were all greater than 80% predicted, which is in the normal range. And the average DLCO was 68% predicted. 54% had evidence of ILD on HRCT. For the detection of ILD on HRCT, the combination of FVC or DLCO less than 80% predicted had a sensitivity of 85%, which results in a false negative rate of 15%. So this combination of FVC or DLCO less than 80% predicted had a negative predictive value of 70%, which means that patients with early diffuse cutaneous systemic sclerosis who have normal PFTs only have a 70% probability of not having ILD on HRCT. Now, this was a study about the impact of ILD in a complete nationwide cohort of scleroderma patients in Norway. Here I'm showing the distribution of FVC percent by extent of fibrosis on HRCT in the 650 Norwegian patients with available HRCTs. You can see that in the group with less than 10% fibrosis, which is the middle bar, approximately 40% had FVCs greater than 100%, which is represented by the green. Even in the group, Even in the group with greater than 10% fibrosis on HRCT, which is represented by the rightmost bar, approximately 15% had entirely normal FVCs of greater than 100% predicted. Another 45% or so had FVCs in the 70 to 100% range, which is represented by the yellow right here. Now, technically, greater than or equal to 80% is normal, so it's unclear how many in this yellow region had normal FVCs, but presumably many did. And this is all to say that despite having greater than 10% fibrosis on HRCT, a significant proportion of patients still had FVCs in the normal range. And here we see in that same Norwegian cohort, cumulative survival in patients with normal range FVCs of 80 to 100% predicted, stratified by the presence or absence of lung fibrosis on HRCT. The green line represents patients without lung fibrosis, and the orange line represents patients with any degree of lung fibrosis. You can see that in this group of patients with normal range FVCs, those with any degree of lung fibrosis had significantly worse survival than those without fibrosis. Now, despite this, work that we've done has shown that only 60% of scleroderma experts in the US, 69% of scleroderma experts outside the US, and 51% of general rheumatologists report routinely ordering HRCTs in their newly diagnosed scleroderma patients. Moreover, among rheumatologists who do not routinely perform screening HRCTs, we found very little consensus among rheumatologists regarding indications for screening HRCT. Now, these data show what rheumatologists report doing, but we wanted to know what proportion of scleroderma patients evaluated at expert scleroderma centers in the US actually undergo HRCTs. So we sought to answer this question using data from the CONQUER registry, which some of you might be enrolled in. So the Collaborative National Quality and Efficacy Registry, or CONQUER, is a multi-center prospective cohort study of adults with early limited or diffuse cutaneous SSC. Early disease in this cohort is defined as a disease duration less than or equal to 5 years from onset of the first non-Raynaud symptom. Enrollment began in June of 2018 and is ongoing. Participants were recruited at that time from 13 centers in the US, including Columbia and HSS. And this particular study included participants who enrolled between June 6, 2018 and February 1st, 2020. So 80% of participants enrolled in CONQUER underwent an HRCT at some point during their disease course. However, there was significant variability by CONQUER site. So for example, at one site, only 33% of participants had undergone an HRCT, while at 2 of the other CONQUER sites, 100% of participants did. Now, here I'm showing the percent of patients with each of these clinical features who underwent an HRCT. So for example, 84% of participants who were SCL70 positive had an HRCT. And as I mentioned earlier, SCL70 is a well-known risk factor for the development of interstitial lung disease. 91% of patients who had crackles on their lung exam had a CT. 82.5% of those with the diffuse subtype, which we recognize as also as a risk factor for ILD, had an HRCT. And approximately 80% of those with moderate to severe shortness of breath underwent HRCT. So we identified several factors associated with performance of an HRCT in our univariate analyses. And these were African American race, crackles on lung exam, and FVC, FEV1, and total lung capacity less than 80% predicted. Anti-centromere antibody positivity was inversely associated with performance of HRCT. So that means you were less likely to get an HRCT if you had the centromere antibody. And in a multivariable model controlling for all of these factors listed here, anti-centromere antibody positivity remained inversely associated with performance of HRCT. Crackles on lung exam were still positively associated with HRCT performance, but this was no longer a statistically significant association. Now, there are some rheumatologists, even some scleroderma experts, who have, a long-held belief, I would say, that centromere antibody positivity is protective against the development of progressive ILD. And sometimes centromere antibody positivity certainly can be protective, but that's not always true. So in a post hoc analysis of data from the census trial, which I will go over in some more detail a little bit later in this talk, we found that patients with SSc-ILD who are anti-centromere antibody positive do in fact experience a decline in their FVC over time, and that perhaps with treatment we can prevent that decline. So I recently had the privilege to co-lead and co-first author the American College of Rheumatology and CHEST ILD guidelines, which covered the screening, monitoring, and treatment of ILD in people with systemic autoimmune rheumatic diseases, including systemic sclerosis. And these guidelines conditionally recommend the combination of PFTs and HRCT for ILD screening in people with a systemic autoimmune rheumatic disease at increased risk for ILD. Now, given that over 50% of people with systemic sclerosis develop ILD, I would say that people with scleroderma are definitely at an increased risk for ILD. So all patients with scleroderma should be screened for ILD with both PFTs and an HRCT. So let's move on to the treatment of SSc-ILD. Tremendous progress has been made over the years in the treatment of SSc-ILD. And here's a timeline showing the publication of key clinical trials in scleroderma-related ILD, starting with the Scleroderma Lung Study 1 back in 2006. We now have 2 FDA-approved medications for the treatment of SSc-ILD, nintedanib, based on the results of the Census trial, and tocilizumab, based on the results of the Fascinate and Focus trials. Other medications that I'll also discuss today that are used for the treatment of SSc-ILD are mycophenolate mofetil and rituximab, and less commonly now, cyclophosphamide. So let's review the data from these key clinical trials. Scleroderma Lung Study 1, or SLS1, was a randomized double-blind placebo-controlled trial of 158 adults with limited or diffuse scleroderma and SSc-ILD. Participants were randomized to receive oral cyclophosphamide up to 2 milligrams per kilogram per day, or placebo for 1 year. And the primary outcome was the forced vital capacity at 12 months. This histogram shows changes in the percent predicted FVC from baseline to 12 months. You can see that a greater percentage of participants receiving cyclophosphamide had improvement in their FVC than those receiving placebo. Conversely, a greater proportion of participants receiving placebo had worsening in their FVC than those receiving cyclophosphamide. And the p-value was less than 0.01 for both comparisons. This graph shows change in FVC over 2 years in SLS1. There was a statistically significant benefit of cyclophosphamide compared to placebo at 12 months, with a maximum benefit at 18 months. But the effect collapsed by 24 months. Because cyclophosphamide has significant toxicity and prolonged use increases the risk of cancer, there was a need for a safer immunosuppressive agent that could be used for a longer period of time with sustained benefit. And that brings us to mycophenolate mofetil, or MMF, and Scleroderma Lung Study 2. SLS2 was a randomized double-blind trial of 142 patients with limited or diffuse scleroderma and SSc-ILD. Participants were randomized to one of 2 parallel treatment groups: MMF, 1,500 milligrams orally twice daily for 2 years, or oral cyclophosphamide up to 2 milligrams per kilogram per day for 1 year, followed by placebo for 1 year. And the primary outcome here was FVC at 24 months. This histogram shows the frequency distribution of change from baseline FVC to 24 months. A greater proportion of participants receiving MMF had improvement in their FVC than those receiving cyclophosphamide. And conversely, a greater proportion of participants receiving cyclophosphamide had worsening in their FVC compared to those receiving mycophenolate. However, the difference between the treatment arms was not statistically significant. The DESIRES trial was a randomized double-blind placebo-controlled trial that was conducted at 4 hospitals in Japan. 56 adults with SSc-ILD, a modified Rodnan skin score of 10 or more, and expected survival of at least 6 months were randomized to receive rituximab intravenously weekly for 4 weeks or placebo. The primary outcome here was absolute change in their skin score 48 weeks after initiation of the study drug. But one of the key secondary outcomes was change in FVC % at 24 weeks. Over the 24-week study period, the FVC of participants in the placebo group, represented by the blue line, declined, while the FVC of those in the rituximab group, represented by the red line, remained essentially stable. The difference between groups was statistically significant. Rituximab also led to an improvement in the modified Rodnan skin score compared to placebo. And based on the results of this trial, rituximab was approved for the treatment of scleroderma in Japan. The FOCUS trial was a randomized, double-blind, placebo-controlled phase 3 study of 210 adults with diffuse scleroderma for up to 5 years, SSc-ILD, a modified Rodnan skin score of 15 to 35, and elevated acute phase reactants. And just so you know, patients did not have to have ILD in order to enroll in the FOCUS trial, but many people did. Participants were randomized to receive tocilizumab, 162 milligrams subcutaneous weekly, or placebo for 48 weeks. The primary outcome was difference in change in skin score from baseline to week 48, and one of the key secondary outcomes was difference in distribution of change from baseline to week 48 in the FVC % predicted. Now, in this graph, the left panel shows all participants in the trial, and the right panel shows the 136 participants with SSc-ILD. You can see that over the course of the 48-week trial, the FVC of participants in the tocilizumab group, represented by the red line, remained essentially stable, while the FVC of participants in the placebo arm, represented by the blue line, declined. And this was a statistically significant difference. At week 48, participants with SSc-ILD in the placebo arm had a decline of 255 milliliters in their FVC, while those in the tocilizumab group had a decline of only 14 milliliters in their FVC, for a difference of 241 milliliters. Now, regardless of the extent of ILD on HRCT, whether it was greater than 5 to 10%, greater than 10 to 20%, or greater than 20%, the FVC of participants in the tocilizumab arm, represented by the circles, remained essentially stable, while the FVC of participants in the placebo arm, represented by the triangles, declined. The Census trial was a randomized, double-blind, placebo-controlled trial of 576 patients with limited or diffuse scleroderma and SSc-ILD. Participants were randomized to receive nintedanib 150 milligrams orally twice daily or placebo for at least 52 weeks. Background MMF or methotrexate was permitted, and the primary outcome was the annual rate of decline in FVC over 52 weeks. Here we see the between group adjusted difference in annual rate of decline in FVC over the 52 weeks. So over this 52-week period, the adjusted annual rate of change in FVC was lower in the nintedanib group than in the placebo group, a decline of 52.4 milliliters per year in the nintedanib group compared to a decline of 93.3 milliliters per year in the placebo group, for a difference of 41 milliliters per year. And here we see the observed change from baseline over time in FVC. The curves for change from baseline in FVC separated by week 12 and continue to diverge, with decline being much more notable in participants receiving a placebo than in those receiving nintedanib. Now, I just want to again highlight the ACR CHEST guidelines for the treatment of ILD in people with systemic autoimmune rheumatic diseases, including SSc. In these guidelines, mycophenolate or MMF was conditionally recommended as first-line treatment for SSc-ILD. Tocilizumab and rituximab were also conditionally recommended as preferred first-line therapies for SSc-ILD. Cyclophosphamide, nintedanib, and azathioprine were conditionally recommended as additional first-line treatment options. And there was a strong recommendation against the use of glucocorticoids in patients with SSc-ILD, given the risk of renal crisis in patients receiving higher dose steroids. So let's move on to touch on some clinical trials and observational studies that are ongoing now in systemic sclerosis. So earlier in this talk, I mentioned the National Conquer Registry, and here's a map of all of the Conquer sites. Conquer is now enrolling from 19 sites throughout the country, which is great. There are 2 sites here in New York, Columbia and HSS, and over 1,200 patients have been enrolled nationwide, including over 100 from my center at Columbia. And basically anyone with systemic sclerosis is eligible to enroll as long as they have a disease duration less than or equal to 5 years from onset of the first non-Raynaud symptom. And so what does participation involve? It really involves just taking the clinical data that's gathered during a routine visit with your rheumatologist and entering it into a central de-identified database. So your name is not attached to anything, but we would enter your HRCT report, your PFT data, your skin score, things like that. And then the only extra components required of participants are filling out questionnaires, usually every 6 months for the first couple of years, and then once a year, and then some extra blood at the visit, usually every 6 months for the first few years, and then once a year. So if anyone's interested in participating, feel free to reach out to Dr. Gordon or to me. And it's a great study to be a part of, and it is sponsored by the Scleroderma Research Foundation. Now, this is a really exciting study that I wanted to mention. This is the Conquest clinical trial for patients with SSc-ILD. And this Conquest clinical trial actually grew out of the Conquer registry, and it's the first ever platform clinical trial in rheumatology. And basically, platform clinical trials allow for the testing of multiple compounds using the same trial infrastructure. So once a site opens Conquest, the Conquest can stay open indefinitely. We don't need to apply, over and over and over again to test new medications. Any medication that goes into the Conquest trial can go in through this already existing platform, which is really nice. And so basically in Conquest, people with SSc-ILD who meet eligibility requirements consent to the overall master protocol and to all open therapies. Right now, there are 2 therapies that are open, and I'll go into that. So participants are then randomized to either therapy A or therapy B. And we know, and the patients know, whether they're randomized to therapy A or therapy B. That's known. But after that, participants are further randomized to either get the active medication or to get the placebo, and that is double blind. So the patients don't know, and the investigators, we don't know if we're getting the active medication or the placebo, but we know whether it's the drug A group or the drug B group. And then the nice thing about this, one of the nice things about the study is that participants who are in the placebo arm basically serve as the comparator group for both medications. So it actually cuts down on the number of patients who need to be assigned to the placebo arm. So people can actually be randomized 2 to 1 actually to receive medication or placebo. So you're more likely to get the study, one of the 2 study medications in Conquest than you are in a study that randomizes 1 to 1 or 50-50. And the 2 medications that are currently being tested in Conquest are both very exciting. One is nerandomilast, which I will talk more about, and the other, is amlitelimab, which is currently approved for atopic dermatitis. Now, there are several advantages for the Conquest platform, both for patients and for the scleroderma community at large. So again, patients are in the shared placebo arm, and patients have the opportunity to support research that gets rapidly funneled back to the scleroderma community. All of the placebo data, and this is really unique, all the placebo data from this trial are owned by the Scleroderma Research Foundation and are available to be used by the scleroderma investigative community. So Dr. Gordon, Dr. Lakin, I can say hey, we have this really important research question that we want to ask using the placebo arm from Conquest, and we can do that, which is really nice because traditionally, if a pharmaceutical company is running the trial, they own all of the data. What's also nice about Conquest is that all medications that are put into the platform are selected by the Therapeutic Selection Committee, which means that only high impact agents are advanced to the platform. And then again, that's a very efficient use of the placebo arm, and fewer people are assigned to that arm. So as I mentioned, nerandomilast is one of the medications being tested in the Conquest platform trial. And some of you may have heard of this recently because it was just approved by the FDA for the treatment of idiopathic pulmonary fibrosis, or IPF. And it's currently under review by the FDA for the treatment of progressive pulmonary fibrosis. And these two studies that I'm showing here were published in the New England Journal of Medicine in June of this year. And just to show you the top line results from the progressive pulmonary fibrosis trial, of the 1,176 participants with PPF who were included, you can see that those receiving nerandomilast, whether the 18 milligram or the 9 milligram dose, had a significantly smaller decline in their FVC at 1 year compared to those receiving placebo. And if you look here on the right, the FVC curves for the nerandomilast groups separated from the FVC curve of the placebo arm very shortly after randomization. It was actually quite impressive. So 324 participants in the study of nerandomilast for progressive pulmonary fibrosis had autoimmune ILD, and 75 of them actually had SSC ILD. And so just like in the overall study population, those with autoimmune ILD receiving nerandomilast, whether the 9 milligram dose or the 18 milligram dose, had a significantly smaller decline in their FVC at 1 year than those receiving placebo. The main side effects of nerandomilast included some diarrhea, but not as bad as diarrhea from nintedanib, and some weight loss. Those are sort of the big adverse effects. So I'm going to move on to sort of one of the hottest topics out there, who many of you might have questions about, and I'm happy to take all of your questions at the end, and that is CAR T-cell therapy. So first, what is CAR T-cell therapy? Well, CAR T stands for chimeric antigen receptor T-cell therapy. It is a cell-based gene therapy that changes the genes in a patient's T cells to help them attack other types of cells. So T cells are a type of white blood cell. Now, CAR T-cell therapy is FDA approved to treat some types of cancers, including some types of leukemia, some types of lymphoma, and multiple myeloma. And it's now being trialed in several autoimmune diseases, including SSC, lupus, the idiopathic inflammatory myopathies, including dermatomyositis and polymyositis, severe refractory rheumatoid arthritis, and multiple sclerosis, among others. And here's a schematic of a patient's journey through the CAR T-cell process. So first, blood is collected through an IV, basically to isolate a patient's T cells. The cells are then frozen and sent to a cell therapy lab where they are genetically modified to express the chimeric antigen receptor, or CAR, on the surface of the T cell. These CAR T cells are then grown and multiplied in the lab. And this process can take several weeks, and sometimes there can be a delay in manufacturing. But a few days before the CAR T cells are given back to the patient receives low-dose chemotherapy, usually cyclophosphamide and fludarabine, basically to make room for the T cells, for the CAR T cells, and to help activate them. And then the CAR T cells are given back to the patient through an IV. And finally, the CAR T cells bind to the target cell of choice and kill them. In most CAR T trials in patients with autoimmune disease, that target cell is a B cell, but sometimes it's an NK cell, or natural killer cell. Patient then stays in the hospital for several days, sometimes 1 to 2 weeks, to be monitored for any side effects. So what are these side effects? The main side effects of CAR T cell therapy include cytokine release syndrome, abbreviated CRS, and ICANS, which stands for immune effector cell-associated neurotoxicity syndrome. So cytokine release syndrome is characterized by fever, low blood pressure, muscle and joint aches, and sometimes shortness of breath requiring supplemental oxygen. ICANS, again, it's a neurologic syndrome, and Patients can experience changes in level of consciousness that may be difficulty to arouse or have sudden awakenings. They can be confused or agitated. They might have trouble speaking or understanding, tremors, seizures, loss of balance. And other potential side effects that we see include low blood counts and infections. So how do we treat CRS and ICANS? Well, that really depends on the severity. So if someone, let's say, has CRS, but just has a fever and their blood pressure is stable and the patient's otherwise well, we just monitor closely. But for more severe cases, we give steroids and tocilizumab. We also give patients anti-seizure medication prophylactically to try to prevent the development of seizures. And so this is hot off the press. I'll show you some preliminary data from the Bristol-Myers Squibb CAR T-cell trial that was presented at the American College of Rheumatology annual meeting last month in Chicago. And I am an investigator on this trial, just in terms of disclosure. So 26 participants with scleroderma had been enrolled and treated with CAR T-cell therapy by the time of the data cutoff for this presentation. The median follow-up time was 81 days, so from as low as 10 days to as long as 424 days. The median age was approximately 50 years. The majority of participants were female and white. The median time from diagnosis of scleroderma was 1.8 years, and the median modified Rodnan skin score baseline was 32, so pretty high. And here you can see a list of all the therapies that participants had tried prior to enrolling in the CAR T-cell trial. And patients had tried really a median of 3 different therapies prior to enrollment, anywhere from 1 to 6 in terms of number of therapies tried. Now, 19 participants had been enrolled long enough to have a valuable outcome data. And of these 19, 84% had diffuse scleroderma, and almost approximately 53% had SSc-ILD. And here are the side effects that we observed. The cytokine release syndrome, or CRS, was the most common side effect, experienced by 54%. 27% developed ICANS, 35% had low cell counts, and 27% had infections. The majority of side effects occurred shortly after infusion of the CAR T cells and resolved quickly with standard management. So you can see most of the side effects occurred between days 0 to 29, and then many fewer after that, out to day 90. And there were no deaths. Now, all CRS and ICANS events were brief and reversible. The 2 more severe events of ICANS were grade 3, and even both of these events resolved completely within 5 days. So was there a benefit that we can see of CAR T-cell therapy? Again, this is very preliminary data, but among 10 participants with SSc-ILD that I'm showing in the slide, there was an absolute increase in the percent predicted FVC of 2.3% at 3 months. Of 6 participants with SSc-ILD who had 6 months of follow-up data, there was an absolute increase in the FVC percent of 6.4% at 6 months. Now, this is interesting because for existing treatments of SSc-ILD, we talk about stabilization of lung function or slowing down the decline in lung function. But here we're actually talking about an improvement in lung function. Of course, with the caveat that this is a very small sample size, but an interesting trend, I think, nonetheless. So what about improvement in skin thickening in participants with diffuse scleroderma? So the skin score trajectories of 16 patients with diffuse scleroderma and at least 1 month of follow-up are shown in these graphs. The 10 participants with at least 3 months of follow-up had a median decrease in skin score of 7.5 points at 3 months, which is a 21% relative decline in their skin thickening. The 4 participants with at least 6 months of follow-up had a median decrease of 13.5 points in their skin score, which is a 33% relative reduction in their skin thickening. Now, there was no control group for comparison. And again, this is a very small sample size. As of the time of the data cutoff, 96% of participants remained off of medications to treat their SSc-ILD and or skin thickening. So who might be eligible for CAR-T? So one study that we are actively enrolling requires that patients have a disease duration of less than or equal to 7 years from the first non-Raynaud symptom. And patients could be eligible if they have ILD with an FVC or DLCO less than 80%, or progressive ILD, or a skin score between 15 and 35 with rapid progression if their disease duration is less than or equal to 5 years from the first non-Raynaud symptom, or a skin score greater than 35 with an elevated SED rate or CRP, or if they've had a prior event of renal crisis but have a stable creatinine and are not on dialysis, or if they have cardiac involvement of their systemic sclerosis. Another study that we have will enroll patients up to 10 years from their first non-Raynaud symptom, which is actually great because most clinical trials for SSc exclude patients if they've had scleroderma for more than 7 years. This particular trial is for patients with moderate to severe, active, or progressive SSc. So patients need to have ILD with an FVC less than 70% or DLCO less than 65%, or progressive ILD, or a skin score of at least 30 with an elevated SED rate or CRP, or a skin score of at least 16 with active skin progression over the past year. So I want to wrap up by mentioning one more study, Vessel ILD, which is my NIH R01 funded study. The goal of this is to elucidate the relationships between the blood vessels in the lungs and the blood vessels in the fingers, lung function, and ILD in people with systemic sclerosis. So the study basically involves a baseline visit during which participants undergo a chest CT with IV contrast, nail fold video capillaroscopy, so we can see your nail fold capillaries on a screen, endopat, which is a non-invasive way to measure blood flow to the fingers, PFTs, echocardiogram, a blood draw, physical exam, and questionnaires. There is a much shorter visit at 1 year that consists of PFTs, a blood draw, physical exam, and questionnaires. So people with systemic sclerosis are potentially eligible if they have a disease duration less than or equal to 7 years from the first non-Raynaud symptom and are not taking medication for pulmonary hypertension. So if you're interested in participating in a clinical trial or a clinical study, feel free to reach out. Our email address at the Scleroderma Center at Columbia is scleroderma@cumc.columbia.edu, and I'm happy to take any questions.
Is CAR-T actually changing a patient's blood chemistry, the makeup of their blood?
That's an interesting question. It's certainly yes and no. I mean, it changes these specific types of T cells, but that's it.
So you take their T cells and you change them?
Yeah, you genetically modify them. It's gene therapy. So people have to be followed long-term out to 15 years, just like people have to do in all gene therapy trials in this country.
Some people have thought about it being like having a living drug in your body forever, so that the drug is there and persists. It's not a drug, it's a cell, but using a strategy that persists in you instead of taking exogenous medications forever. So it's interesting, it's promising in oncology.
Yeah, I've heard about also TIL therapy, but that's for tumors, right? CAR-T is for blood.
CAR-T is also for tumors. It's also, like I mentioned before, it's FDA approved for some kinds of leukemia and lymphoma. And they're also studying it, CAR-T cell therapy now, for some types of solid tumors.
Is it ongoing, or is it just a one-time infusion of it?
It's a one-time infusion of cells. And pretty much, at least once you get it, you can't get it again. At least right now, for autoimmune diseases.
Please use microphone so everyone else can hear your question, okay? Thank you very much.
So, last question is, has there been any involvement with people that have scleroderma longer than 7 years? I mean, is that something that you would want to look at, or it's just too late?
Well, and people here, correct me if I'm wrong, but the data that we have so far, I believe, have not looked at anyone who's had disease longer than 7 years. But this other trial, which is sponsored by AstraZeneca, will enroll people up to 10 years. But we don't have those data yet. Yeah.
10 years.
Why is that?
Why
aren't they taking people that have had it longer?
So most clinical trials in scleroderma don't, because they want people with earlier disease, thinking that it's more modifiable and more active early on.
Is there any current study that's related to the hypopigmentation right here? Reversing that?
Not that I'm aware of, but I'll ask some of our other skin-focused people.
Probably not looking at hypopigmentation primarily. There are a number of studies that look at skin as an outcome measure. So the focus is more on the skin. And then when you're doing a clinical trial, it's a little bit different than like living with the condition or from my perspective, treating somebody just in the office. So when I'm seeing someone in the office, I'm thinking about all the different ways their disease affects them. And then if I give them a therapy, I'm thinking about all the different ways that maybe this could help, or that I wouldn't expect it to help this or that. When you're doing a trial, you're really you have to focus in a certain way to learn something. And then it winds up not being generalizable to the whole patient. That's just sort of part of it. So when we do skin trials, most of our studies so far, and then maybe it'll change in the future, use an outcome measure called the Modified Rodnan Skin Score, which is a way we measure how active and thick the skin is. So then we focus on that in the trial. Now, definitely in practice, when you're giving a medicine that improves skin activity and thickness, you will see hypopigmentation improving too. But it's like kind of slow and so that particular problem, which is a doozy of a problem, it isn't always like focused on in studies. Another thing with doing studies, and I'm sorry I'm talking so much, but again, so study design in scleroderma has really evolved like over my career and Dr. Spira's career and before us too. And at this point in time in study design, the focus is usually on earlier disease because of what Dr. Bernstein said about trying to hit things when it's modifiable. So that's for the study. Once the study is successful, then that can still be applied to people in different cohorts. Sometimes when we do a study in folks who have had scleroderma for a very long time, we might not see an improvement depending on what we're measuring, if there's a lot of damage that's occurred over that period of time. And so these disease durations are used as a cutoff at this point. Maybe they'll change over time.
Yeah, the only thing I would add to that is we do think the pathophysiology, what's going on in the body, is different very early in the condition and later in the condition. And so there's increasing recognition that there are other things that need to be looked at that are things that are later on, because most people, fortunately, with scleroderma are living for a long time. So the vast majority of the universe of scleroderma patients have more than 3 years of scleroderma or 7 years of scleroderma or 10 years of scleroderma. So there is a little bit more attention to that. The idea that maybe the scarring process in some areas might be reversible. Some of what Dr. Bernstein showed there with lung changes maybe improving might speak to that. To the question about pigmentation, by the way, I just want to advertise on behalf of Dr. Lakin, who runs, I think with Dr. Gordon, one of the skin working groups of something called the Scleroderma Clinical Trials Consortium. Things like that are really important, and they're really important to patients. So she's actually starting to lead an effort, and I hope I'm not like getting ahead of myself, to sort of reach out to patients and understand what other things are important. Like Dr. Gordon said, our trials use these outcome measures that we know the FDA will accept to say a drug works and they'll approve it, but there are things that are important to patients and we need to better understand that. So I don't know if there's opportunities to sign up for anything today where we can get people, maybe even just for our newsletter or something, so we can capture people who might want to weigh in on that as Dr. Lakin starts developing that study.
We could always send out a follow-up email with the link directly. Like, I've been here a while, so I know where to go to your clinical trial page, and I'm scar tissued up. Nobody will take me. But you could also go to clinicaltrials.org or actually through the foundation page, care box, and type in HSS in every trial, put HSS and scleroderma, and all the trials will come up. You have quite a few going on too, I know, right? Yeah.
Yeah, I just have a quick question. I'm not yet diagnosed. I'm being monitored from the Scleroderma Center. I have, according to my doctor, a 70% chance of having scleroderma. Some tests 70. Yeah, SLs, yeah, and then PL 12 something. I've already had the chest CT. I've had a heart something slice test, whatever. And the pulmonary test. But 70% chance says, like, you cancel your barbecue, it's going to rain to me. That's what that means to me. So at what point do you start looking at, my doctor will tell me that, yes, you are a candidate for some trials along the way. How does that work?
Are you followed at sorry, you don't have to answer this question, but let me phrase it as not a question. Ideally, follow at an expert scleroderma center.
Yeah, I'm at Columbia Presbyterian.
You are?
Center.
You're not? Okay, great. So yes, and you can talk to me after if you want, and I can get some more information. But yes, and you can tell me who your doctor is and all that.
Thank you.
Yeah.
Right now, I feel like I have a big cloud over me.
Can I just say something about that? So it used to be the teaching when I was a fellow that if you had that antibody called SCL70, that you would develop systemic sclerosis, you would develop scleroderma. That has changed, and part of that has to do that people are testing more and more people with it, and they also change the methods and how they define what's positive and negative. So I think all of us, I'm sure Elana, I'm sure Jessica, I'm sure Kim have pretty substantial groups of patients that we're following in our practices who come in with SCL70s. Why it was checked in the first place is a big part of why, whether we think it might mean something or not. So sometimes somebody comes in with pain and has every antibody known to mankind checked, and that pops up and something else pops up. That's very different than if somebody comes in feeling achy in their hands with some puffiness with Raynaud's, let's say, and it pops up. I find it very hard to quantify and say 70% or this or that. So it becomes, as Dr. Bernstein was saying, very individual. But it is difficult, and usually the message is don't cancel that barbecue. It depends on the individual patient, but I would say more often than not, that ends up being the message in somebody where we're saying you don't have this. We watch you, we get you neurotic once a year, but then you live the rest of your life. I mean, usually, again, I don't know the details in your individual situation. Thank you. All right. We have a question.
I was just going to ask, how long does it take a clinical trial to become like a common practice of treatment?
That's a great question. It can take, well, I mean, first you have to complete the trial, which can take, it depends how long. It can take a couple of years, more than a couple of years, and then you have to take the, let's say, medication and go in front of the FDA, and that can take some time. So it can take several years. I will say with the medication, nerandomilast that I mentioned, that was just approved for IPF and is now under review for the FDA for progressive pulmonary fibrosis. Once it's approved, I'm just using this as an example, like once that's approved for progressive pulmonary fibrosis, which I suspect it will get approved, that can be used in people with SSc-ILD who have progressive ILD as a treatment. So once it's available and someone, has the diagnosis that it's approved for, it can be used. But it's usually a several-year process from the start of the trial to making it out into the community.
I also, Dr. Spire, I was going to talk to you about this. I saw a study about viruses. They're looking at how viruses may be changing people's, cells, especially their T cells. So I don't know if you're looking into that at all.
I'm not personally.
Yeah, there was a study that got I think a significant amount of attention recently. Looking at Epstein-Barr virus in autoimmunity, and so, and it's interesting, and I would sort of just like from a sort of like a kind of high level way of interpreting it. We have a question like, why do people develop autoimmune disease? And not everybody does. We're all exposed to lots of different stuff, and some go on and develop autoimmune disease. And we do see that folks who develop various autoimmune diseases all have a whole host of genetic markers, but then that isn't necessarily enough. And then what's that second thing that occurs? And so I think that study showed that EBV may be implicated in some. EBV is tricky because it's everywhere. Like probably all of us have been exposed to it. Yeah, sorry, Epstein-Barr or mono. And if we test everyone in this room's blood, all of us will test positive for some exposure at some point. So I think there's a lot more to the story, but viruses in general may be part of what leads to autoimmunity in genetically predisposed individuals, maybe other things too, like environmental exposures and things like that. But it was a pretty cool paper.
Okay, you know what? We're going to also have a little bit of a panel later for broad questions. Are there any other questions really specifically for what Dr. Bernstein spoke about in terms of the trials? And then we're going to take a break for lunch.
Yes, I had a question for you regarding the NIH trial and the relationship to the skin disease like the digital ulcers. You were mentioning that you do some kind of testing for that, and I wasn't too clear about it.
So we look at, it's an observational study, and we're looking at the blood vessels near the nails using like 200 times magnification, so we can quantify those, so we can count them. And we also do something called endopat, which basically you put probes on the fingers, like you're checking someone's oxygen level, and put a blood pressure cuff on and measure the flow to the finger. And that it's all for research purposes. So it doesn't help inform your clinical care. It's all for research.
Okay.
So if you could hold off to the panel, if you guys don't mind, we would like to invite you to get some food in the back, and we would resume the program at 1 o'clock with Dr. Lakin. Thank you so much.
Okay, everybody, welcome back, and we're going to resume the program. This afternoon, we're going to start with Dr. Kim Lakin. Again, I have a bio here, but I think I really know her bio very well. She actually, many of you probably have heard of John Varga at Northwestern. He had been at Northwestern when Dr. Lakin was a resident and may have inspired her to enter this world of taking care of and studying scleroderma. She came here from fellowship, after fellowship, and then stayed on as a clinician and investigator in scleroderma. She's had awards from the Scleroderma Foundation, which did support some of her earlier work. She's had research support from the Scleroderma Clinical Trials Consortium, and right now she's funded by the NIH on an award called a K Award, which they grant to people who they think are going to be the next generation of leading investigators to kickstart their career. And she's already had a lot of impactful work. Today, she's going to talk about skin biopsy as a precision tool in systemic sclerosis. So looking forward to this.
Hi, everyone. Thank you so much for the introduction. So this will be changing gears a bit from the earlier talk, which was more focused on lung, to really come back down to the skin, which is obviously kind of integral to what everyone is experiencing often with this condition. So the outline of this talk, so we'll start with how do we measure skin involvement in scleroderma? And then we'll talk about what we've learned from skin biopsies that have been collected during clinical trials. So one thing is that everything that we've learned about scleroderma, really is due to people who have chosen to participate in our studies. Our observational studies, our clinical trials, provide so much knowledge and really, really help us learn about scleroderma. And these are examples of 3 clinical trials that I know at least one or more of you have participated in one of these studies. So this is the nilotinib study, which was published back in 2014, the belimumab study, which was published in 2018, and the linabazum study, which was published in 2023. And these were studies focused on scleroderma, diffuse scleroderma specifically, with a primary interest in skin involvement. So not an interstitial lung disease specific trial, though people could have lung involvement and join. And we are still learning from the data that we had collected during these studies. So nilotinib was enrolling many years ago. Those skin biopsies that were part of that study, I'm going to present the results of. So it kind of lives on and we continue to learn as the field progresses. We have new ideas. It continues to allow us to go back to the data we have and look again with new questions and really help to better understand what's going on. So first, I don't need to emphasize to this audience that skin involvement really can cause significant symptoms and requires treatment, often with immunosuppressive medications, in order to help relieve the thickening, itch, and inflammation that people can experience. And the way we assess skin most often in the context of our trials and in the office as we're trying to see if things are getting better or not is an assessment called the Modified Rodnan Skin Score, which Dr. Gordon mentioned when we were doing our Q&A right before lunch. So this is an assessment, a physical exam assessment of 17 places on the body where we feel on exam about how thick the skin feels. So it can be 0, 1, 2, or 3, where 0 feels completely normal, 1 would be mild skin thickening, 2 is more moderate, and then 3 is more severe. And so when somebody has mild skin thickening, like a skin score of 1 at that site, we can feel that there's a little bit of thickening there, but we can still see in this example some kind of fine wrinkles that are still there. So it's sort of on the mild side, whereas at a 2, that skin might still sort of move when we kind of pinch it between our fingers, but the fine kind of very tiny wrinkles might have disappeared. And then in 3, which is the most severe skin involvement, we're really struggling to kind of move the skin between our fingers and there's more kind of severe thickening. And we have 17 sites we assess. We add them all up, and then that total number is the modified Rodnan skin score. And the modified Rodnan skin score helps us sort of track the trajectory of skin involvement over time. So before we really had much that was effective for our patients in treating skin involvement, we have observational data that basically showed that people in the first couple years, maybe 3 or so years at a group level, so a lot of different people contributing data, obviously individually there can be differences, but at a group level in the first few years is when we're really seeing that early worsening of skin thickness. And then even if people aren't treated at a group level, there tends to then be a period of stability where things, might not be getting worse or better. And then in the later stages, the skin thickening, even untreated, tends to get softer. Of course, in this example, not necessarily going back to what it was before the disease began. And then we do know, and I was kind of alluding to this, that at the individual level, people have a lot of different types of experiences. While most people do get worse in the first couple years of the diagnosis, some people never really get as thick as others, and some people improve very kind of as expected, like this graph suggests, and then other people tend to stay, with thicker skin, sometimes for longer periods. And a lot of our clinical trials decided, let's really focus our studies on people with this disease duration of 3 years, because we want to see if a medicine's going to work or not, if we can really influence this period of worsening. But of course, when we have people that we're trying to help and improve their skin involvement, we still want to be able to give medications to people later in their disease as well. The other thing is that we talked about pigment changes. The MRSS is not everything that people experience when it comes to their skin. So, we might feel that it could be thick and we write our numbers down and we are told as part of our exam to sort of ignore some of the other features that are important, because the MRSS isn't a skin severity overall assessment, it's a skin thickness assessment. So, some patients can have a very sort of red, inflamed skin, and that isn't part of the MRSS. Or sort of a shinier appearance, that it can be seen as well as also not part of the MRSS. We observe that people can lose hair when skin becomes thicker, and that when skin improves, we can actually see a regrowth of hair on the arm. So that kind of improvement that we can see clinically isn't assessed in the MRSS either. And some other changes, including some of the pigment changes that we discussed earlier, aren't part of the MRSS. And the other thing is, as good as we think we are at being able to do this well, sometimes the MRSS can, as we're doing it, misattribute thickening for swelling. So if you are retaining some fluid because of edema or swelling, it might feel thicker on our exam, but then that swelling, it might be easy to get rid of if we start treatment, and we might think, oh wow, we've done a really amazing job for the skin thickness. But if we did a biopsy before and after, maybe the thickness is the same, but the fluid is improved. And then also sometimes at the later stages, some of the skin might be quite thin, but more tethered to the structures around it. And so we might see that we think, oh, wow, we can't move the skin, but actually it's quite thin at this point. And whether if we're thinking of a medication to target skin thickening, we might accidentally or kind of inadvertently attribute sort of this phase to thickening, or someone might. And the other thing is, one time we did a survey, it was back in 2020, and we asked a lot of scleroderma specialists how they score the skin. And you could think about it a couple different ways, and many people probably could also share that it's not like the entire forearm is exactly the same at every single place you touch it. Some areas might feel a little thicker, especially maybe closer to the wrist, a little bit softer, closer to the elbow. And so when the doctor's kind of trying to decide how do we give one area one number, they might, they have to decide. They can't just say, if there's differences in the numbers, they can't just pick one. So you could either say that the maximum score is the score. So if there's any place that's a 3, this would be scored a 3. Or you could say, well, most of the skin is mild, so let's score it a mild, even though there's this area that's more severe, that's a 3. Or you could average it and say, 1, 1, 3, that's like a 2. And so we asked people, well, what do you do in your practice? And in North America, a third of scleroderma specialists do it either way. So I don't know if anyone in the room has had the experience of having a second opinion. You might have a skin score that you can see on your clinical note and then go see someone who has a different approach of your skin score. And you might say, wow, like my skin is completely different here than it was when I saw my other doctor. And some of that could be this type of thing, but it also challenges our clinical trials because we're wondering, which should we use when we're trying to determine if a medication is working. So skin biopsies are another way that we assess skin changes in scleroderma. And in our clinical trials, they're pretty regularly used as a way to assess how the medicine that we're studying impacts the skin at a cellular level. So if we give a medicine that's supposed to target B cells, well, we could check a blood test to see are the B cells gone, and we might see that they are. But we're wondering, well, we're not treating a blood problem, we're treating a skin problem. So we want to know, like, if we give you a medicine that has some side effects and they're, you're receiving this medicine, is it actually working where we want it to work? So we can check a skin biopsy and show whether the B cells that we're targeting in this study are actually changing in the skin, where we're actually hoping that they go. And so in our studies, we have kind of developed at HSS our approach to evaluating skin. So we usually do 2 punch biopsies that are 3 millimeters, so very small in diameter, usually right next to each other on the forearm. And the forearm is one place that we choose because it changes more often than the other places. So when people get better, we often see the changes happening there versus at the hand, where sometimes it's like the last to get better or maybe would be harder to heal. So the forearm is where we conventionally do these biopsies. And one biopsy will go to look at gene expression, which is an assessment of what the cells are making. And then one biopsy goes to do histology, which is a look at what the cells are, which cells are there. So you might see that there are certain cell types, and we can look at them in picture and say, aha, like this biopsy has B cells. And then the gene expression is a way to say, okay, but like what are the B cells? What are they doing? Are they active? Or, different signatures related to their behavior. So here, as an example of one biopsy that is sectioned and stained and looked at for different things. These are actually different biopsies, but theoretically we could get all this information from one biopsy. So we look at the whole biopsy and how it appears, and then we can do specific staining. So these are 2 stains for markers of fibroblasts. So they kind of have this brown appearance, whereas these blue stains here are inflammatory cells. So this is an example of a biopsy that had a lot of inflammation. The biopsy here, you can look at thickness and you can see that this biopsy is a lot thicker than this one. And so this was a person who had gotten a lot better during the trial, and the biopsy became smaller and less thick. So we can look at this. And what we saw in our clinical trials was that these really do change at the individual level when people get better. So this is an example of someone who enrolled in one of those 3 trials I mentioned, who at the beginning of the trial had a lot of skin thickening, and 1 year later on the medication, this person's skin improved. So you can see this thickness there's more spaces here. So this area here, where you don't see a lot of white space is because the collagen is very dense, and this looks a lot more open with the white spaces, and that indicates less thick. And then these are the two fibroblast stains that we're mentioning. So fibroblasts are the cells that actually make fibrosis. So the immune cells, maybe they're telling the fibroblasts, hey, turn on and create thickening. But the immune cells themselves aren't the ones creating the thickening or the collagen. They're just maybe informing the fibroblasts to start doing that. So when we target in the skin, a lot of times with an immunosuppressive or immune system lowering medicine, we're really kind of trying to stop the stop the signal to start making more fibrosis. So these are the types of cells that actually create the thickening. And we could see that at the beginning, there was a lot of this ASMA positive fibroblast, it's like an active fibroblast, and not a lot of the CD34 fibroblast, which is a resting fibroblast that we see just ready to go in healthy skin, so that if you were to have a scratch, anyone, the fibroblast can kind of wake up, make a scab, and then quiet back down. So this is abnormal to have no CD34 here. And then when the person got better, we saw that the ASMA really disappeared for the most part, and the CD34 is back, the happy resting fibroblasts. And then, we did a study, this was published in 2021, to see if this was just an individual observation or if this was true at a group level. So we took all of the patients who had participated, all of the data from the nilotinib and the belimumab study, and we said, okay, if the person improved over a year, what happened to their ASMA and what happened to their CD34? And so each of these dots is an individual person, and then the line is sort of their median or representative group number. And you could see that the ASMA in the whole group went down and the CD34 in the whole group went up. And so we said, okay, well, this could be a tool to kind of quantify skin severity because, we have trouble with the MRSS sometimes. Maybe someone's ASMA or CD34 could help us define sort of how active the skin is. So the other piece is the gene expression. So I mentioned we can look at the cells and say there's a lot of fibroblasts here that are ASMA and active, and another biopsy maybe there isn't. But we can also ask, what is the activity? What are the cells making? What are they doing? And so that's what gene expression is really looking at. So what genes are turned on. So we looked at the two fibroblast markers and basically developed this group of genes that seemed to kind of track with the histology so that we could kind of get a whole picture of what's going on, not just what cells are there, but what they're doing. And we looked at each of these dots are one gene, and we looked at, hey, okay, if the person went on to improve at the very beginning of the trial, what was the level of that gene? And we'll compare it to the people who didn't improve. So anything above this red line means it was higher at the beginning of the study in improvers. Anything below the red line was higher at the beginning of the study in non-improvers. So we see most of these genes are up. So the people at the beginning had a certain kind of pattern to these genes, suggesting that maybe we could have known at the beginning of the trial if they were going to improve or not based on this. So maybe we could take this assessment of fibroblasts in the gene signature and be able to tell people at the beginning, at the baseline visit, hey, you are likely to be an improver because people with your gene signatures tended to improve. So maybe we could use this to predict what will happen, which is very exciting because we're okay, this is what we want to do for people. We don't want to say at 12 months, we'll tell you if you improved or not, because everyone can say, I feel better or worse. We want to know at the beginning, will we be better a year from now? So we had all of this data just from 24 people. And so we needed more data to prove if this was true. And so we get access to a second cohort, 81 more people with biopsies. And then we plotted the same plots and we found that the signature was kind of the same in people who improved or didn't improve, maybe even a little higher in people who didn't improve. So we were a little discouraged, maybe this isn't where we should take this. But in science, it's never you shouldn't be happy or sad about the data. it's just another piece of information to learn more. So we said, okay, well, what's different about these groups? Maybe that can help us understand it. And we found that really, like, both groups had the same skin severity score. They had the same antibodies, like SCL70 or an A polymerase III. There's no difference. Similar age, similar sex. But the disease duration was different. So the people who were in this initial cohort had much earlier disease, only 9 months of disease at the time of the biopsy, versus the median number for the second cohort was 29, so 20 full months of difference. Now, 29 months is still really early. That's less than 3 years of time. And like I said, when we're getting clinical trials, really we're looking at 3 years. So these are still early, markers, but we found that this difference is probably clinically meaningful from what we think we know about the trajectory of skin. So 18 months has even been proposed in some studies as maybe the optimal time to study for trials, because everyone's kind of getting worse. So if you want to make a difference, you could start in this early phase. Now, as we mentioned before, if we can find a medicine, show that it works, get it approved, we can apply it to other groups in the future, but we want our trials to show effect if it's going to show effect. And so that, we don't want to give medicines to people that can have side effects if it's not even going to work in the phase where people are really active. So what we wanted to do is to really look at those fibroblast markers, but also the disease, because it doesn't just matter, what is the fibroblast characteristic, but it's like, when did you take the biopsy? Was it the very beginning of scleroderma? Was it very later, much later? That probably makes a difference. So this was published just in September in one of our rheumatology journals, based on our work. And you can see Dr. Gordon, Dr. Spira, and all our other co-authors here. And the purpose is really to look at the skin biopsy features and look at disease duration, and then also to see if we can identify predictors of improvement. And so in this study, we ended up with 105 patients who were enrolled in either the nilotinib, belimumab, or linabazum clinical trial. And we sat down and we scored every single biopsy for the fibroblasts I mentioned, and also specific immune cells. So the B cells, the T cells, and another immune cell called plasmacytoid dendritic cells that we think is important. And some of these biopsies had been available, from our initial studies, and we were able to say, we have a new idea. We think these fibroblast markers matter a lot, and we want to also look at what immune cells are there. So we can cut a new sample from the block of tissue that we keep and do a new stain and answer new questions. So it's really, really helpful and important to have that biorepository available to us. And what we did was we looked at the people, 68 of them, who were taking CellCept, which is one of the more common medications that we use for skin specifically. And 50 came from the linabazum trial and 18 were from the belimumab trial. And the biopsy was done at the beginning. And we looked at the histology or biopsy markers, so these fibroblasts and the immune cells and their numbers. And we also looked at the clinical features, the disease duration, the skin score at the beginning, age, male or female, which antibody is positive, and how long the person had been on mycophenolate. And then we wanted to predict the outcome of improvement in skin. And what we found was that people in the trial, regardless of whether their disease was very early, less than 18 months, or greater than 18 months, the MRSS was the same. So the doctors were kind of scoring people similarly, but under the microscope, there were a lot of differences based on the disease duration. The people with less than 18 months of a scleroderma history had higher ASMA, lower CD34, and more B cells, which are CD20 positive, compared to those who had disease duration later than 18 months, where ASMA tended to be lower, CD34 tended to be higher, and there were fewer CD20 cells. And then that's not to say that no one with later disease had high CD20. They certainly did. It just was not quite as high as that very early group. And so we see that is another example of why we need something better than the MRSS, because basically what we're saying here is that the patients felt similarly on exam, but there was a difference here. And why would we think that the same medications would work exactly the same at the tissue level for people who have very different features under the microscope? And so we built a model. So we put all those features in, and we asked the computer algorithm to say, okay, which of these features are the most important when you're deciding if somebody improved or didn't improve? And basically what we found was that the disease duration was number one, most important. And then the fibroblast markers, so whether the CD34 was high or low, and the sex. And you can see basically that if the CD34 was high and the ASMA was high, regardless of sex, people did very well in early disease. But if the ASMA was high and the disease duration was later, people didn't do quite as well. And this is shown here as well. So in the groups that had high ASMA or high CD34, this green means very high proportion of people were getting better and did quite well and met that criteria for skin improvement at 1 year. And then in the later group, if the ASMA was high, despite 18 months of scleroderma, only 40 to 50% of people improved, which is quite different than ASMA high early. So ASMA being high on its own, if you could tell, like if you just put this into a big group and look to see if it was important, and you didn't take into account for the disease duration, it would probably cancel itself out. But we can see now that the skin biopsies are important, but it also depends on when you're looking. So when it comes to CD34, high CD34 in early portended sort of a higher odds of improvement. And high ASMA early also was associated with higher odds of improvement. So these markers in the early phase might signal a time where the skin is very receptive to treatment with CellCept or mycophenolate. Whereas if the disease duration was over 18 months and ASMA was still high, it was associated with less improvement at 1 year, suggesting maybe it could be a signal for a more treatment refractory moment that could benefit from other additional treatment. But on the flip side, if the disease duration was over 18 and the ASMA was low, people tended to do pretty well. So why give anything else? So this can be really helpful when we're thinking about it clinically, and somebody's been on CellCept and we're wondering, okay, are you going to get better on mycophenolate in a year or not? We can use these markers to help us understand it. And we also found that if ASMA was high and the person was later, there tended to be more B cells compared to high ASMA or low ASMA later, which suggested that maybe this is a group that would really benefit from something that targets the B cells like rituximab. So some key takeaways, skin biopsies help us understand how the medications are impacting the skin at a tissue level, and they change with clinical improvement. And that skin fibroblast profile with disease duration could potentially predict the improvement on mycophenolate. And these data really support a potential expanded role of skin biopsies. Right now, we very rarely, if ever, use them to diagnose scleroderma or monitor scleroderma in the clinical setting. We almost always get them in clinical trials. Maybe there's a way that they could be useful outside of the clinical trial setting, but we need to test this in another kind of data set before it's really prime time. So it's not something that we are kind of doing at this exact moment clinically, but we will kind of move forward and kind of proving to ourselves this is worth it before we put anybody through a skin biopsy that might not be necessary. But I think it's really helpful to learn about how we can move toward a more precision-based treatment approach where we look at individuals beyond just the skin subset like diffuse or the antibody and say, okay, well, what does your skin look like? Let's treat that. So we are recruiting. So a thing that we didn't talk about here is that, we look at skin biopsies. We're also doing a study of skin ultrasound and looking with high frequency ultrasound at the skin and how thick it is and how the tissue characteristics are. And we are recruiting for that, both individuals with scleroderma as well as similarly aged people without scleroderma, so that we can understand what the signature is of the ultrasound of scleroderma and compare that to people without it. And then also we can look to see how it compares to the MRSS and other measures of how people feel. So we can get a quantitative number for scleroderma severity that maybe is better or more precise than the MRSS. And then we're also looking to see if the ultrasound could predict how people do over time and save someone a skin biopsy. And we are still recruiting. We're recruiting patients for biopsies, but also people without scleroderma for biopsies as well, so that we can really understand specific things that are unique to scleroderma and compare them to healthy tissue that does not have scleroderma and understand everything better. So if you're interested in participating in either of these, you can contact us, our outstanding research coordinator, Shmita's emails here, or just call our offices and we'll put you in the right place. There are also flyers out front. So again, none of this could be possible without patience and enthusiasm and a willingness for people to work with us and understand that there's a lot that we don't understand and a lot of goals we have to try to do better and treat in a more precise way. And hopefully when we give this talk, a few years later, we'll have, changed some of our approaches. And this is our group. This is our appointment, form. There's a fast track form you can fill out if you're interested in seeing one of us. So I'd like to also thank our funders, the NIH in particular, for supporting this work, and the National Scleroderma Foundation as well, which was, part of the initial studies. And I think we're going to save questions.
No, what we'll do is this. I'm just going to come up here. So we are going to do a little bit of a panel later, and I'm actually going to probably pull a couple of chairs up so the three of us will take questions. But if there are questions specific to this talk, now would be a good time to do it. And I do want to sort of say this is, and I'm looking at some of the patients, the people in this room who have been part of clinical trials, and sometimes someone participates in a clinical trial and we say, well, this trial was not a successful trial in terms of proving that this medication worked. When we do clinical trials, it really enormously as long as we do them well, it really advances treatment and understanding of scleroderma. The work that Kim did here was based on one very promising trial, the belimumab trial, which is now being looked at, or Benlysta, in a large registration trial nationally. One small trial that we did here with a drug that probably isn't going to be part of the treatment of scleroderma, although it was an encouraging small study, and then one convincingly negative trial, which was the linabacim study. But what Dr. Lakin's work does is take that to learn how to really understand and treat this disease better. So this concept of personalized medicine is so important as we learn more, and hopefully with the ultrasound, more and less invasively, about who to treat with what. Like the little point you made, or not so little, about the B cells persisting in that refractory group. All of these there, you heard a little bit about CAR T earlier. That targets B cells. We know about rituximab. That targets B cells. So not everybody is going to be expected to respond to anti-B cell therapies, but this idea of teasing out who might respond to what and doing it earlier and doing it less invasively is sort of the platform of Dr. Lakin's career, of what she wants to be moving towards. So for us, this is very exciting as investigators.
There's a question.
Yes.
For the clinical trial, can you do the ultrasound and not the skin biopsy, or do you have to do both? Or are they different studies?
So they are different studies. So you can do the ultrasound without a skin biopsy, and we still are learning so much from that. And then the clinical trials, the protocols can vary. Some clinical trials have optional skin biopsies, and some have kind of required skin biopsies. So that can be different depending on where you do.
Okay, great. Because I might be interested in the ultrasound one. Not sure about the skin biopsy.
Ultrasound would be wonderful. Yes, please get in touch. I love that.
Thank you.
Any other questions about this specifically? Yeah.
I kind of do have one. I'm not sure. I didn't see something mentioned about this calcinosis part of the whole skin involvement. Is that something that you guys are also studying?
Yeah, so this really is looking at like skin fibrosis and the different features of the inflammation of the skin itself. And then there's calcinosis, which is almost a separate thing and treated differently. It is so important. Actually get that question about how do you treat calcinosis on all kinds of types of talks because it's so top of mind and really important for patients. And we do need better kind of strategies for calcinosis, absolutely.
I think I have another one related to CellSup, which is the mycophenolate.
Yes.
So I was on mycophenolate 3,000 milligrams, and I had to kind of come off of it because there was kind of like a risk with ADH that I developed. ADH as in atypical ductal hyperplasia. I did see an increase in my skin involvement once I was off of it. So I'm assuming that mycophenolate is more so the drug more specifically related to helping with the skin issues, or?
Well, so mycophenolate can be helpful for other manifestations of scleroderma. It's also a first-line medicine for the lungs. We chose to look at it specifically here because it is commonly used. So it was the most common in our group of patients, but other medications are also available. And if we have more data for things like rituximab or methotrexate, we can repeat this type of work and understand, responses to specific medicines. But we chose CellSup because it was more common, but it isn't only a skin medicine and it isn't the only skin medicine either.
Okay, and one more question.
Yeah.
It might not be, I don't know if it's related to the skin at all, but what about IVIG?
Yeah. So IVIG sometimes we use when, we've tried other things, in particular if there's muscle involvement.
Okay.
Tends to be good for muscle inflammation as well. And so very few people tend to be on it. And then in the clinical trials, it's generally you can't be on it in the clinical trials.
Okay.
And so our data set, we're looking at a really kind of clean data set where everyone came in at the exact same time and we're on very similar medicines and from the trial standpoint, but repeating this in an observational cohort that doesn't have like rules about what medicines you could be on would give us more information about those types of treatments. Okay. So we should do that. We'll look into it.
Awesome. Thank you.
All right. Okay. Thanks very much. Thank you, Dr. Lakin. And our next speaker, who I'm thrilled to invite, is Dr. Jessica Gordon. Dr. Gordon is also an outstanding clinician and a clinical investigator and an educator in this area. And actually, I should mention Dr. Gordon, Dr. Lakin, and we all serve on the medical advisory board of the Scleroderma Foundation National. I think I'm being very self-promotional. We're the only institution with more than one person, and all three of us are on it, but chosen for a variety of reasons. And Dr. Gordon chairs the Patient Education Committee. She's also been in a leadership role with, I think, the Conquer or Conquest study that you've heard about. She's led many studies here. And she's going to talk, we're going to switch gears a little bit to address a different component of systemic sclerosis that people struggle with, understanding and managing Raynaud's phenomena and digital ulcers.
All right, thank you so much. So yes, and this talk will be, we'll mention some research, but it's going to be a little more clinically focused. And hopefully, since it's that change in season where Raynaud and ulcers can be coming up a lot more, will be applicable. So in terms of an outline of this talk, I probably don't need to define Raynaud phenomenon and digital ulcer for this group, but I'm going to anyway. And we'll go over recommendations on management for both. So Raynaud is typically a triphasic color change. So first white, then blue, and then red when the blood vessels open up. Triggered by cold and can be triggered by stress and involves the digits, so fingers, toes, nose, earlobe, tongue. Episodes can last 5 to 20 minutes after removal of a cold stimulus, sometimes longer. And 3 to 5% of the general population has primary Raynaud phenomenon, meaning they have this and they don't have an autoimmune condition like scleroderma in association with it. And Raynaud and scleroderma occurs in almost all patients. So not everybody, but almost all will have it, and it's very important and impactful in terms of pain, distress, decreased function, and impaired quality of life. And then digital ulceration occurs as a continuum of Raynaud. So in scleroderma, there's more than just that change. There's also disease in the blood vessel, and that leads to damage of the fingers, and these digital ulcers can occur, and that occurs in about half of patients with scleroderma. And they can occur early in the course of disease and associated with decreased ability to work and a huge impact on just daily living. So Raynaud is a disorder of blood vessel thermoregulatory control. So what does that mean? So the skin is an organ that is extremely important in helping us maintain the correct body temperature. And the skin itself doesn't need that much blood, but blood flow to the skin is key in keeping us the right temperature. So that is what we see, and I think of it in that way in terms of primary Raynaud. The additional features that happen in scleroderma have to do with the way the blood vessels are affected by the process of scleroderma. And Raynaud looks a little different in folks with scleroderma than it does in folks with primary Raynaud. And this winds up being important for rheumatologists to be able to pick up, because we see lots of folks with Raynaud and have to figure out if it's primary or secondary. So when it's associated with scleroderma, it may be more asymmetric, different on one side than the other. It's more likely to involve thumb. The attacks are longer and more painful. And when we start seeing damage occurring to the fingers, so we'll use terms like digital, like a pitting scar, which is, do I have, take this, there. So digital pitting scar, we're seeing damage at the tip of the fingers, then we know something else is going on. We can also see something called, like the tips of the fingers, I think you can see in the right photo. So that acral means the tips of the fingers. So you can have bone absorption there, and amputation can happen also, or gangrene of the fingers. Uncommon, like less commonly, but it is something that can occur and is extremely painful. So this is that vasculopathy. Okay, so the blood vessels in scleroderma are different. And here we go. Now, is that showing? Okay, so this is if we obviously wouldn't do this in clinical practice, but if we took a biopsy, or if we looked under a microscope at an artery from the finger, a digital artery, it looks like this in a patient in an individual without scleroderma. There are different layers. So this inside layer is the endothelium, and there are these other layers of the blood vessels, and they all get very thick and change in individuals with scleroderma. So you can see this middle layer gets very thick and different. The endothelium, the inner layer, is a little different too, and it's more reactive. And the outside layer, or the adventitia, is also thickened. And so it looks very different. So those attacks last longer, and the effect of it is different in scleroderma. So this is just another way to see that. It's a normal response to the cold for a blood vessel to constrict or get small, but it's different and more profound in systemic sclerosis because of those blood vessel changes. So digital ulcers are a challenging problem in scleroderma. It can happen in about half of patients. It has all these impacts in terms of pain, inability to work or function in daily life. It can be disfiguring, and then there's potential for infection of digital ulcers, because whenever the skin is open like that, there's that skin isn't able to protect you from infection anymore. That infection can become deep. So we think about bone infections or osteomyelitis that can occur. And then if you're getting infections, then you need to go on antibiotics. There are complications that can happen there, and it can really be impactful. So this is a point I like to make and take a little bit of time with, because I think it's good for understanding. It's helpful for me to understand the different ways I need to address problems with digital ulcers. And so not everything works for everything. And I'll say, like, you may, the physicians who know about this are ones that are really thinking about scleroderma and ulcers. If you have an ulcer just as a complication and you're seeing like an urgent care or your primary care or something like this, they may not be thinking of it in the same way. So I want all of us here to understand this. So one is these types of ulcers that I've been talking about so far. So the medical term for it is ischemia, and that means not enough blood flow. So you're having these attacks of Raynaud, not enough blood is getting to the tips of the fingers or the tip of the toe, and we get an ulcer there right at the tip of the finger there, okay? Or, in that area, sort of around the nail, we might see it. And that's just from not enough blood flow. So the way we would approach it in terms of trying to prevent them from happening again, trying to help it heal up, is we're going to give medicines that are going to try to improve blood flow. So all of our kind of approaches we're thinking about how do we get more blood there. All right, now there are ulcers like this, extensor surface ulcers. So like ulcers over the knuckles here and here can happen. You can see them on the elbows too, or other areas if there are contractures. So they occur at bony prominences due to microtraumatic events. So this happened to me the other day. I reached into my purse. It was messy and full of all kinds of stuff, and I needed something quickly. And of course, I scraped my finger, and it hurt. So these kinds of microtrauma events happen all the time. You're talking and you hit your hand. When you have contractures, that little bit of trauma has a bigger impact. It can really open up, and then the contracture itself is exerting a force that is preventing it from healing. And it's hard, and it still isn't getting enough blood flow because of the Raynaud and because of everything. So it's a little bit different in terms of treatment approach. You have to kind of, wound care becomes very important there, protecting the ulcer from further microtrauma becomes very important. So just sort of different things to think about. And then some ulcers are multifactorial. So you can have one of these ulcers and then they get infected and then it's getting worse. Or maybe there's calcinosis underlying it also, and an ulcer on top of calcinosis. And so then we get some inflammation from that too. So we have to think about all this in terms of understanding ulcers and why it's not getting better, or what can we do to prevent another one from happening. But overall, this is a very impactful aspect of scleroderma, and definitely an area of interest of research in different kinds of dimensions too, but an important one for us to be thinking about and addressing in terms of ongoing care. So how do we manage it? So there's a lot of, I'm going to call them non-pharmacologic measures, right? So things that aren't medicines that are helpful, and you guys are experts in this. So if anyone wants to share what the most important or most helpful thing is, I'm open to hearing it. I'm sure I'm missing things. The kinds of points that I always try to make is keeping the core warm, layers, being able to kind of adjust for different temperatures. You don't want to get sweaty and wet when you're too hot, and then you go outside and then you're freezing. Hand warmers can be helpful. If there's, there'll be time at the end for product recommendations and things like that. And space heaters. I'm interesting, like pregnancy really improves Raynaud, but, I don't know that you would get pregnant just to help with that. And what to avoid or be prepared for. So the other thing that winds up, it winds up taking up a lot of like mental bandwidth, because you really have to think about how to be prepared before you leave the house. It's an extra thing to think about. Changing temperatures. So this season, or I think also, like April, March, that time when it's the season changes are really tough. Avoiding certain medicines that are vasoconstricting. So sometimes certain decongestants like Sudafed can make things worse. Smoking and secondhand smoke can also make things worse. Tools that are like vibrating, it's like a drill or, whatever else we might be using, those things can make it worse too. So there are treatment, so shifting away from that, and we can come back to it in the questions if you guys want to share helpful things that have been helpful for you. But there are recommendations, and that are we have a bunch of different recommendations that are generated by different groups. So this group is a European group, EULAR, okay? That's a rheumatology group in Europe, and they have some specific guidelines for Raynaud that we can look at. I'll pull up some other guidelines too. We don't have US specific guidelines for this, but that's okay. I like thinking about guidelines because these are very, available, and these are things that any rheumatologist would know to look at. It's not hidden or obscure or anything like that. These are things anyone can refer to, and I think they do sort of describe our general approach. But because these are European guidelines, not everything actually is available in the US, so it's a little bit different. And I think that's important for us to think of. So in terms of treating Raynaud, there are some first-line treatments. Oh, here, I'll make one other point on this. So again, this is the way doctors look at a combination of all the medical evidence. So when Dr. Bernstein was presenting today, she showed some guidelines that she was part of generating, and Dr. Lakin was part of generating. And groups of physicians look at all the evidence that's published. It's a lot, and they can provide guidelines related to level of evidence and strength of the recommendation based on the types of studies that are done, the numbers of studies and things like that. So these are all high level of evidence with high strength of recommendation. So in scleroderma, first line treatments are calcium channel blockers. So those are medicines like nifedipine or amlodipine. Felodipine is another one. This is the type of them. So there are different types of calcium channel blockers. These are dihydropyridine ones. They act in a certain way, and that's a first-line therapy. We use that a lot. So phosphodiesterase inhibitors can also be considered. So those are medicines like sildenafil or tadalafil. Sildenafil is Viagra. Tadalafil is Cialis. And I've been very happy over the last. So in the U.S., these are off-label. So insurance doesn't have to pay for them if they don't want, because they're off-label. So like I have this letter that I have used for years to get insurances to pay for that works. I just changed the patient name. And then, but over the last several years, these medicines, the price has come down and they're a lot more available. So that's very nice. So even if it's off-label, a doctor can prescribe it. So it's, approved for whatever else, but it's still available. You just need a prescription. All right. So, and then IV iloprost is another one. So IV iloprost, and there are some other medicines like iloprost. These are prostaglandins. These are also off-label in the US, but they're available in Europe for this. These are really hard to access here because they're so expensive and generally IV. And require monitoring. So this is tricky, these types of medications. So a little bit different in the US here. And then digital ulcers, you see these same sorts of choices. They also in these guidelines talk about bosantin. So bosantin or ambrisantin, these are medicines on the market in the US for pulmonary arterial hypertension. And these are also expensive and a little bit tricky to get, but I have been able to do that. They're less available than the phosphodiesterase inhibitors. They're actually a little bit trickier to use too because they have other interactions with medicines. So you do have to kind of look out for a lot of different things, but they are, I'm sometimes able to get insurance companies to pay for that, even though they're expensive and even though they're off-label for this indication. So that's sort of an overview. These are just the sort of the ways we kind of look at these different treatments. I think I presented it in the last slide, but obviously easier to get certain treatments than others, and really probably higher level of evidence for those other treatments too, the ones to get. And then these are British Society guidelines. This adds also thinking about antiplatelet therapy. So like aspirin, maybe just a baby aspirin, or clopidogrel, the brand for that is Plavix. And those, and sometimes to think about statins. Statins are like Lipitor or Zocor, those kinds of cholesterol medicines. They may have an effect on the inside of the blood vessels, the endothelium. Those are things to think of. If you see, so this is the level of evidence here is 2C. That's lower because the studies aren't so clear that those are helpful, but they're, good to think about and reasonable. And then it comes back to these IV medicines like prostanoids, or iloprost or epoprostenol. These are IV medicines. There are some oral versions and some inhaled versions of those medicines too. Not a tremendous amount of study on that. There was one oral treprostinil study. It didn't hit its endpoint, although most of the investigators who participated in it did think it was helpful. But that again, expensive and a little hard to get in clinical practice. So not, in the US especially. And then we can also think about some other approaches like digital palmar sympathectomy or other kinds of approaches. So I'm going to show some pictures about that. This is sort of summarizing that same type of, these are the same sort of these are the meds that we really think of that are key, that are in our guidelines. What else do we sometimes think of? So this is a list of different kinds of medications that are sometimes considered. So what this means is, and I definitely see folks who are on these trying them for Raynaud, and I'll sometimes use them also. That means maybe there's one or two studies that are out there that show maybe it's helpful, or that it would make sense that it would be helpful. So there are other kinds of medicines to use. So nitroglycerin, this is one that is used pretty commonly, and it is available as a pill or a cream. Has anyone ever used nitro? Yeah, so this one is used pretty commonly. It's if you're using the pill, it can be headaches are pretty common, and there's something that can develop with it called tachyphylaxis, which means like your body gets used to the medicine and it stops working so well. So that could be a problem with that. When you use it topically, or like put a little cream right here on the finger to help open things up, it can help temporarily. It's messy though. It like you can't like touch your dog or your baby or anything like that when you have it on. And so it like the cream winds up being something that isn't so practical. And there are interactions with that one too. One that's important is it interacts with phosphodiesterase inhibitors. So sometimes I'll catch that interaction and just make sure that, if a patient maybe has some nitroglycerin that they grab from time to time if they have a bad attack. We don't want to be doing that if you're taking tadalafil or sildenafil, because of that interaction. It can really make the blood pressure come down. So I like to mention that. Other kinds of medicines that also dilate blood vessels are these angiotensin receptor blockers, so losartan, valsartan. There are others. They also dilate blood vessels. They're commonly used to treat hypertension. Statins can be used. There was a study that looked at fluoxetine or Prozac helping with Raynaud. It was helpful in a very small study. I'll sometimes try that if somebody's blood pressure is so low that I can't use any of these other meds, which all tend to lower the blood pressure. And then this is another type of blood pressure medicine that also can be used. So what do we do in refractory cases when all of these kinds of medications aren't enough? So in the US, sometimes we do, I'm going to talk about the prostacyclins, Botox, and digital sympathectomy, okay? So IV prostacyclin, these are the ones that are available in the US. And there are, again, like I said, some oral ones and inhaled ones, but they're just a little difficult to access. But we have, at our center, if we need to use it in an urgent case. We actually have to admit to the hospital for this. That's not true in Europe, and in some other centers they can get it, but it is very hard to get the insurance approval for it. So this is something that can sometimes be used. Botulinum toxin or Botox is a little bit more accessible. Again, like what can we grab? What do we have access to? So here. So Botox is, used for lots and lots of different things. We think of it for, the first thing I think about is for wrinkles. It's also used for headaches and muscle spasticity and other indications. It's used for hyperhidrosis or sweating a lot. So there are other indications for it. This is off-label, but it can be injected in the finger, right around where the blood vessel is, and it leads to vasodilation because the way it works is it relaxes muscles, and in those blood vessels there are very small muscles, or muscle cells, so they can relax, and that can help with increasing perfusion. I think it's helpful. It's not perfect, and the pictures look very good. I don't know. These are selected, right? These are the ones in the papers. So I think there can be variable effect, but it is really something to think of, and it is, I find, a lot more accessible when I need to do something when there's an urgent flare. It's not approved so frequently. Folks will need to pay some amount of money for the Botox itself, but those prices kind of come down, and the procedure itself isn't difficult. So I refer to dermatology for this, and they have it in the office. I probably could learn how to do it because it's really not technically hard, but I don't carry Botox in my office. So that accessibility becomes a little bit tricky. Digital sympathectomy is another consideration that we sometimes use when things are really bad and we've tried everything else. So, this is a specific case that was done by one of my surgical colleagues here, Dr. Fufa. She gave me these photos. And this is an angiogram. So this is a diagnostic test where dye is injected into the arteries, and you can see the blood vessels. And there's supposed to be another blood vessel here that we see, but it's really not seen very well. So the ulnar artery would be here, but it's not well visualized. And in this patient, when she would try to extend the wrist, it would get worse because of the pressure on that blood vessel. Dr. Fufa was able to take her to the operating room and make an incision. She did here, here, and here, and then is able to strip some of that outside area of the blood vessel, the adventitia, that thickened tissue. You can strip that. There are nerves in that area that cause more of the vasoconstriction. So those nerves are disrupted and stop causing that vasoconstriction. And it also sort of because it just makes the blood vessel a little bit bigger. It allows it to open more when that tissue isn't. So you get more pressure. If you think of like plumbing, like a bigger pipe is going to let more water in and give you more blood pressure. So this is a way of taking off some of that constriction of the blood vessel without like opening it up completely. So it's still function. So they release the adventitia, and that helps. That's an operative way or an operative approach to digital sympathectomy. There's another way to do a sympathectomy where anesthesia is injected. This is, you can orient yourself. This is someone with their arm raised here, and that's their armpit. There can be anesthetic injected to hit these nerves, and that causes blood vessels to get bigger also. And then there's a surgical approach too that can follow up. When you do the injection with the anesthetic, it's just temporary. If you do a surgical approach, it's more invasive, certainly, but because this is getting into the chest, so they're actually making incisions and getting into the chest wall here. And I don't use this very often, but occasionally. So I don't think I've referred a patient for this in several years, but it can be helpful sometimes. So those are some of the ways to approach when things are difficult, as well as the baseline ways to approach. Wound care is very important too. So this is for all ulcers. I said those extensor surface ulcers, wound care is key, and that is definitely true, but also ischemic ulcers aren't going to heal up well enough without the wound care that you need. So when ulcers are active, they really need to be kept just a little bit moist so that they can heal. So not like wet, and not a wet bandage, which will be a breeding ground for infection, but just a little moist so that the cells can heal it all up. Bandaging is important for protecting it, bandage, you don't want to have like too much adhesive, especially right on the ulcer. So your adhesive or the Band-Aid is in another area. So like the type, just in terms of using non-adhesive dressings for that. Different products can be helpful. So some folks like vitamin E oil. I think that can be pretty helpful. Medi honey is another one that is non-prescription and can be helpful. I like Aquaphor, which is pretty basic. And I'll prescribe mupirocin a lot. Mupirocin is a topical antibiotic. Sometimes it's hard to know, is it infected? Could there be a little infection there? So that's kind of nice to have on hand if you need it. And as the ulcer heals, it can be open to air for more extended periods of time. And there's kind of a balance there that folks get the hang of, but can be a little tricky. Sometimes wound care clinics are helpful too. But I generally sometimes no, though, because I have sometimes seen maybe folks following with podiatry or wound for something on the toe, and I do like to be a little bit conservative about debriding wounds. So debriding is like when they cut off tissue. I think we have to be very gentle and selective with that. Infections can happen, right? Because these are, open skin, and so this is a risk. So definitely look out for increases in pain and redness and warmth. Those are all signs of infections. If there's drainage, if it looks a little different, those would be signs to reach out to your doctor for evaluation. I mean, I think I get emails or messages in the online portal about ulcers and infections definitely every week. And what I just do is have my patients send me a photo. It makes with some patients, I know they know when they need antibiotics, but I like being able to check it too and just see how bad it is, and then we just get on antibiotics but then anyway, it's important to start those. They're necessary when there's an infection. But this is, an important area for further research in terms of the types of research that is going on now. There's a lot looking at improving patient-reported outcomes. So these are different ways of, I think anyone who's participated in research has had to fill out loads of forms. You may have to fill out loads of forms just to see your doctor regularly. At HSS, they definitely ask patients to fill out a lot of forms. But these are outcome measures that can be used. And then, we validate them in this context, and it winds up being a powerful tool for research. There are a good number of these types of studies going on. Will be part of another one that is really working on creating good outcome measures. Vascular imaging is being used, and in terms of therapeutics, in preparation for the talk, I went through clinicaltrials.gov to see everything that's going on. The therapeutics I'm seeing are sort of different ways of increasing the validity of the types of treatments that we currently use. So what I've described so far really does show sort of what's available. I think a major point of improvement for us would be if we can have increased access to the IV prostacyclins or the oral prostacyclins for this treatment, so that may happen ahead. It tends to happen with time as these meds become generic, et cetera. So with that, I'm going to thank you for your attention. You've been great at paying attention to all of us, and I can take questions, and we'll have a panel now for questions about anything.
We actually couldn't control it here, so we called building services.
Oh, okay.
So here's what I'm doing, Chantal. Maybe what we'll do is, maybe you stay up there, bring Kim here, and we can take some questions.
I'm going to grab.
I'll grab it. Jessica, I want to maybe mention you were an investigator in the iloprost trial.
Yeah.
So that trial.
So we did a study. This was during pre-pandemic and then during the pandemic. And it was, how do I turn it on? Okay, looks like no one had this. So it was looking at iloprost to try to get it approved for Scleroderma Rhino. I just need some water, sorry. The talk took gave me a little tickle. Okay, so iloprost is a medication that's used in Europe for Raynaud and digital ulcers, and also for pulmonary arterial hypertension. And it was, a study was done here in the US. We were a site for it. And it was, the medication eventually got approved for frostbite treatment in the US. So it's it used to not be available in the US at all. Now it is approved for frostbite. The study in Scleroderma Raynaud was a negative study. It didn't show an effect of the medication. And it hasn't been published yet, so I don't have slides on it. But it was interesting because when the study started pre-pandemic, and then had to go on hold at the beginning of the pandemic. Almost all research was stopped at that point in time in like March 2020 and paused. And then a few months later, we were able to open up, for treating patients again and recruiting into studies. When you looked at the data at the end of it, all of the pre-pandemic data actually looked very promising and very good. Like it worked pre-pandemic, and then the post or during pandemic era, it didn't have the same kind of effect on patients, and it was interesting. I mean, I guess I'm not sure why, but my bet would be because of all the kinds of different lifestyle changes that were made, it wasn't shown, right? No one was leaving their house at all. I would guess that was the reason.
I also just wanted to highlight, you had a ton of good information in that talk. A couple of interesting things. One, when you talked about the medications or other things in the environment that can contribute to Raynaud's, I would say one of the most common things I see in practice, and you had it on there, were some of the stimulants that are being used more and more now. So things like Adderall and Vyvanse, and we see this a lot contributing to people who come in often during college midterms. I'll have a patient come in who's a 19-year-old with her mom, and the patient has new Raynaud's, and the mom's concerned that it's a condition, may represent scleroderma. And then when mom leaves the room, I ask the child, have you been using, Adderall to help you with midterms or something like that. So that's one I really want to highlight. The other really interesting thing I thought when you talked about the fluoxetine or the Prozac for Raynaud's, anything that causes stress, contributes to Raynaud's. So cold is a stressor. So it's that fight or flight response that leads you to clamp down on your blood vessels. So when I think it was maybe even the Columbia group years ago that looked at fluoxetine in Raynaud's, it wasn't clear whether it was that platelet effect or whether it was that just kind of calming things down a little bit. Really makes a difference for Raynaud's. So I thought that was interesting. I wanted to comment.
Any questions?
Maybe I'll ask a question.
I have a question about reflux. Is there any other studies or new studies about reflux in scleroderma? Or any you've done it?
So there are some new therapies. And I don't know if it's new to this room, but it's out there. There's a medication called Voquezna that is relatively new, that is pretty effective in terms of as an acid reducing medication beyond the proton pump inhibitors like omeprazole and all the things that end in prazole, and Pepcid or famotidine, those kinds of medications. Voquezna is another option if if those aren't doing the trick for you.
You said Voquezna?
Voquezna,
I'm on it actually. Yeah, it kind of replaced Dexilin.
Right.
So both Japanese named pharmaceuticals.
So the only thing is that, like in a lot of other areas of treating scleroderma where we've made great progress, I don't think there's any specific scleroderma reflux related medications being developed, but rather borrowing on advances made in the treatment of reflux in general. There is more and more being studied about how to study, how to collect information about it in patients with scleroderma, similar to what you said about, I think you made the point about Raynaud's and just learning how to better measure it in clinical trials. There are ways we're trying to better capture what's changing. There's a researcher at UCLA who even brought up the question of whether we could be modifying the disease in the GI tract the way we modify disease in the lungs by using immunomodulatory therapies earlier. We don't have evidence that that's the case, but we're just trying to study it better, just like we're trying to study. So a lot of the effort in research is sometimes learning how to better study a problem.
Thank you.
I have a question regarding going back to the Raynaud's with sildenafil. I'm on sildenafil, not sure it's doing what it's supposed to do, and prazosin. And if that's not, I'm going to go back to trying a calcium channel blocker. My first try didn't work really well. Is there any concern with coming off of sildenafil? I do not have pulmonary arterial hypertension. I know that's what it's also used for, but I don't have that. So is there any concern if I stop that? Like, could it be preventing pulmonary arterial hypertension? But I don't think it's used that way. But is there any concern with coming off of it?
Yeah, so in terms of the pulmonary hypertension, I don't think it's preventing the development of pulmonary hypertension. I don't think there's anything to suggest that. I mean, in terms of, just treating Raynaud and switching therapies, sometimes it's hard to know, is it not doing anything or is it helping a little and you're not seeing it? So if you stop it at the same time you're trying something else, then it can get just hard to know what happened there. So, I try to make one change at a time so we can assess that. But I don't know if you're already on that and the prazosin, if you add something else, or is your blood pressure going to get too low? So there's that kind of balance. But you might see what happens if you just stop the sildenafil, then add the calcium channel blocker, so you could at least know what's what.
That sounds good. I was most concerned about potentially stopping sildenafil because I don't have pulmonary arterial, but I don't want it to be like, oh my God, and that stuff's going to get wacky.
The doses used for pulmonary hypertension as a treatment are also much, much higher. So we don't really think of it that way. You had a question.
My question is about the skin overall. For burning, itchiness, or shininess of the skin, rheumatologists would refer you to a dermatologist, and sometimes they would provide you creams. I guess my question is, does dermatology even matter, or should you be asking more from your rheumatologist?
Yeah, that's a great question. We definitely partner with dermatologists here. The topical creams tend to be helpful for specific situations. Like sometimes there's an area that could be very itchy, and there are different things that can kind of be soothing for that area. So for example, sometimes we'll use like a Sarna or even a topical steroid for a brief period. But as far as sort of the kind of management of the skin fibrosis and trajectory, it generally requires the oral medications. But other things come up. I mean, just an example of how they can be very helpful. So on mycophenolate, it's a medication that lowers the immune system, and anyone on immune system lowering medicines should have a skin check for their whole body to look for things like non-melanoma skin cancers. That kind of thing is still important. And so having that dermatologist as a reminder to not only manage your scleroderma, but also kind of prevention of complications from treatment and other things along those lines can also be very helpful. Do you have other?
most dermatologists, are they familiar, like, special, do you need to go to ones that are specializing in scleroderma, or since it's rare?
Yeah, so the question's about whether any dermatologist is kind of all right and they'll be familiar enough, or you should go to a specialized center. We do have dermatologists that we work very closely with who are expecting and kind of able to handle issues related to scleroderma specifically when we refer patients. I do think there is a benefit to that. And when Dr. Gordon was talking about things like Botox injections for ulcers or Raynaud, the dermatologists that are used to that sort of referral that from us are able to help with that. So I think it's helpful, but I think it depends on your specific skin issues and how difficult it is to come to wherever the dermatologist is.
Yeah, not every center has that. We have a couple of people we work with here. There's a woman at Mount Sinai who's a dermatologist and a rheumatologist, but I don't know how much she focuses on systemic sclerosis. There's a dermatologist down at NYU who's sort of globally interested in rheumatologic and systemic autoimmune diseases. There are things like calcinosis where we sometimes have help from dermatologists, although it's not always clear how evidence-based those, interventions are. So I think it's very kind of institutionally dependent also.
We also sometimes will refer for telangiectasias. There are certain laser therapies that are recommended as an option. They aren't permanent, but they can be very helpful. So dermatologists can also help with other things beyond skin thickening.
Yeah, there was the question before about pigment changes, for example. Sometimes they have things that they can be helpful for to lesser and greater extents cosmetically. For areas where the skin is too darkly pigmented, it might not be thickened anymore, but or conversely, hypopigmented, meaning less pigment in the skin. But the telangiectasias one is important. Many people have those, even with scleroderma that we call limited, where it's not affecting a lot of the body in terms of the skin thickening, but there's these little cherry red spots, which can be very prominent, and it's just sort of managed as a cosmetic issue, with laser, which is mostly temporizing. So people have to keep revisiting that, but dermatologists are helpful with that.
I have hello. Hi. I have a quick question about just the trials, right? So I know most of the trials are like specific medications, testing one at a time. Has there been any trials related to like 2 medications used at the same time to see how that works?
So there haven't been trials there haven't been trials where they've used, that I'm aware of, combinations of therapy as the experiment.
Okay.
Some trials, though, are more permissive or less permissive about what other drugs can be used during the trial. So you heard about that linabacim trial, that Dr. Lakin has used a lot of the samples from that trial, but that trial took a very liberal approach to other therapies. So it said patients in the trial could be treated with whatever their treating physician feels is the best treatment for the scleroderma, because the linabacim was very safe, and we're going to add linabacim to that. So there were people in that study on multiple medications plus linabacim, or multiple medications and plus placebo. But there haven't been, the way large drug studies done right now, it's very hard to use more than one drug together for a variety of reasons, even pharmacoeconomics. Actually, one study that's using 2 drugs in combination that are very sophisticated drugs that I'm aware of is our study. So we're doing a study, you keep hearing about B cells. So there's this emerging thinking, and we were interested in this like a decade ago, that B cells might be very important. So we're doing a study now where we're looking at everyone gets mycophenolate, and the study intervention is people get the drug called rituximab for 2 infusions, and then afterwards they get belimumab or Benlysta injection. So Benlysta is that's a way to even more aggressively suppress the B cells that we think might be driving the disease. And the other group gets, for every 2 patients getting the active therapies, the other group, who's also getting their CellCept, so they're not being left free of therapy, is getting placebo infusions and placebo Benlysta injections for the year. And all of those patients then get another year, all 30 patients, or all of the patients enrolled in the trial, including the ones who got placebo at the beginning, get a year of Benlysta. That study is close to enrollment right now, but that's actually a study that we were able to utilize the idea that these drugs are complementary. And the problem is that's a study that we are the sponsors of. So that's an HSS study. We got support from industry to do it, but it's our study. Industry usually won't invest in a trial that's using 2 different drugs. And I'm trying to think of examples where that's different. Dr. Gordon's leading the Conquest trial that you heard about here, where there's that platform that Dr. Bernstein spoke about, but that's not 2 drugs being used in the same patient. You're either randomized to one drug or another or placebo. So that's an interesting idea, though, because we know in other disease areas in rheumatology where we think there are drugs that might be very complementary if we could get these trials funded.
Yeah, I'm actually really glad that you mentioned the rituximab and the CellCept, because it's something that I think might possibly work for me, because I have been on the CellCept and I just started rituximab, and I just would like to experience just like having both to see how it helps. So that's good to know that you guys are also looking into that.
So this even separate from trials, and I'm sorry for talking so much because but we're pretty aligned on this. So that combination of mycophenolate or CellCept plus rituximab is something we've turned to quite a bit. Okay. And Dr. Lakin just studied what people do as scleroderma experts after their patient doesn't respond to one drug or another. And that's one of the answers you got, that people will add Rituxan to the CellCept to give you more potential encouragement. About 10 years ago, and it's part of the reason why I'm a little bit, just want to be guarded about how crazy enthusiastic we get about CAR T therapy. About 15 years ago, there was crazy enthusiasm for something called hematopoietic stem cell transplants, which was a very, 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 very aggressive therapy. We've had some patients do that. But recently there were some studies, I think you presented one of these, where they looked at a group of patients getting that super aggressive therapy compared to people getting that combination of mycophenolate or CellCept plus rituximab. It wasn't a head-to-head comparison, it was retrospective, but that strategy seemed as effective as that incredibly aggressive therapy. So it's something I think all 3 have you had patients on that combination?
Yeah. And it's also employed in other contexts too. So like just in rheumatology, if we're treating other autoimmune conditions, you might use that combination. So that doesn't, tell us does it work for scleroderma, but it does help us know it's safe for folks, or relatively safe for folks, with autoimmune conditions.
Can you share any findings that you know about between the correlation of COVID infection and the onset of scleroderma or the progression of scleroderma?
I don't have any. So we did a study that was published just after the pandemic about the experience of patients with scleroderma and getting the vaccine, and then also getting infections. So this isn't exactly your question, but I'll give you the results of that. So the people who were asked about this were already diagnosed with scleroderma, and people who responded basically had similar side effect profile to getting the vaccine as people who were in the studies who were not didn't have an autoimmune problem. And, the most common flare, a very low proportion of people had a scleroderma flare after the vaccine. It was around like less than 10%. And the most common manifestation that flared was fatigue. And it wasn't it didn't necessarily like last. So that was all very reassuring that people's scleroderma didn't kind of take a big turn and change in characteristics. Nobody reported a severe flare or a severe sort of new manifestation after the vaccine. And then about a year later, we did a study now that, more time had passed about people who had gotten infections. And then we also looked at boosters. And so even like, subsequent doses of the vaccine and boosters seem to be even kind of more data of similar kind of safety in scleroderma. And then the infection itself, when it came to scleroderma, didn't connect with like new severe disease worsening. It's hard to study whether an specific infection can cause, that type of study is really difficult because you need to get everybody at risk to be in the study, beforehand.
The other challenge I really think at this point is I think the estimates are that maybe 70% of the country has had COVID at this point. I think that's the number. So, or it might be higher. So it's very hard to know. I think anecdotally, not just with scleroderma, but with some other rheumatic diseases we take care of, we've wondered, or patients have come in, I had COVID and a month later this started or that started. But as Dr. Lakin said, it's just very hard to tease it out. There are some conditions that are like you can pinpoint the day they started. So there's something that's not relevant to this called polymyalgia rheumatica, where people often wake up one day and they just feel like they've been hit by a truck. They're achy all over. And we've had a few patients develop that actually after the vaccine or after COVID. And then we like kind of followed them or looked at least in their records to see did they behave differently than the condition behaved in idiopathic disease, and it really didn't look like anything was different. And so we think it probably was idiopathic disease, just with this coincident exposure.
Have you had any patients that after the COVID vaccine have had heart inflammation?
I have not. I know that can be a side effect. Typically is most common in sort of younger men. I haven't personally seen it in my patients. I don't know if either of you have had myocarditis after the vaccine in a patient.
I've had two people in my personal life who had that actually. One was a girlfriend of my son, one of my son's frat brothers, and another was my brother-in-law's nephew. But those were both like kids. One was 20, one was 15. I think your question, though, does come up a lot. So we'll have a patient with scleroderma and myocarditis who's, let's say, which is inflammation of heart muscles. Some people have that as part of their condition. And especially if they're in that younger age range, like, it's most often, at least I think it was like 16 to 29-year-old males, where it was seen in general, where that question will come up. And usually we were still recommending the vaccine to those patients because those were also patients who were at the highest risk, in the day of getting really damaged by COVID, because those patients with that kind of heart inflammation were often on a lot of immunosuppressant therapies. But if that's the prism that's coming, that question's coming from, that's something that came up a lot as a question. But mostly, I would say there's been pretty uniform recommendations in those patients that you don't necessarily avoid it, but it's been a question.
Quick question for Raynaud's. Most of the solutions are vasodilative, correct?
Yes,
So,
a lot of them, yeah.
Is there any solutions that promote blood vessel growth, like angiogenesis? And is that possible? I mean, from what I've read, and you had a slide that said during pregnancy, Raynaud's improves. So I've heard that amniotic tissue or proceeds of a placenta and can produce angiogenesis in people for wounds and healing and Raynaud's?
I can't think of anything that we're using that's actually pro-angiogenic. It's more vasodilatory or part of the blood vessel issue is endothelial activation. So the internal layer of the blood vessel is more kind of sticky. And so some of the medicines may stabilize endothelial cells to some degree. In pregnancy, the reason Raynaud gets better is because blood vessels are very dilated in pregnancy. It's true that there's angiogenesis, especially in the placenta, but systemically, blood vessels are just very, very dilated. So, you can see blood pressure changes and things like that related to that in pregnancy. Can you guys think of angiogenic?
Not specifically angiogenic, and there are some things that we're concerned about angiogenesis in scleroderma. Conversely, like when we see some of the telangiectasias or things like that, or other beds where that might be going on, the endothelial cell story, that the health of those lining cells, though that has been thought about a lot. Even you saw statins on the list. And other than, there's some general sense that, well, if you have less atherosclerosis, your blood vessels are healthier in general. But one of the ideas behind that was that there was a couple of studies from Japan, I think, where treating patients with statins increased something called circulating endothelial cell precursors. So your bone marrow released more of these cells that go on to differentiate and line blood vessels in a more healthy way was the idea in a way at the time. But this whole idea of modifying vasculature, not just opening it up, I think is sort of one of the holy grails of vascular biology in general. And in larger vessel vasculitis, so there are other forms of inflammatory blood vessel disorders where tightening of the blood vessels down the road is really your problem, like something called giant cell arteritis or Takayasu's. These are unusual causes of inflamed blood vessels, but down the road, they're just thickened, they kind of stiff blood vessels. And there are all kinds of strategies being looked at to increase the elasticity and sort of decrease the smooth muscle cells in the vascular thing. I think with angiogenesis specifically, I haven't seen much in scleroderma.
If you're dealing with scleroderma and myositis, are the treatments generally the same, or does that patient would need something more, less, or more?
So you do have to think about things a little bit differently if you're treating both. So there are some treatments that will work for both issues, the muscle inflammation, maybe like the CK is high or the weakness related to that muscle inflammation versus the other manifestations of scleroderma, but some things are different. I think there's a higher level of evidence for the use of IVIG in a myositis manifestation, whereas IVIG is probably helpful in other aspects of scleroderma, but maybe it's not as well proven. So that's one kind of way of thinking of one treatment. Another treatment that we think of in myositis are corticosteroids like prednisone or medicines like that. When the muscle enzymes and the muscle inflammation is very, very high, sometimes we really need to use prednisone to help bring down that inflammation before too much damage occurs. Sort of depends on what's going on. So in just straight up scleroderma, we try to avoid using high doses of steroids because there's a risk of scleroderma renal crisis or high blood pressure with that. And then in myositis, there's really more of a clear indication to use those medicines. So when you have both, you're sort of like on a tightrope, kind of trying to balance both things. My approach to that is really just to be very thoughtful about my dosing and my monitoring on it. So if somebody really needs the steroid, we just have to be extremely mindful, monitoring blood pressure like every day and things like that, and then try to get the dose down as low as possible. So you can see there are some treatments that are great for both, or probably great for both, and other treatments that are better for one than the other. And so you have to really think about everything. It's a lot to balance.
I would just add the study that Dr. Spira mentioned where we were surveying a lot of scleroderma specialists. We asked over 100 people who treat scleroderma, consider themselves a specialist, like how do you treat, the skin? So you say, like, oh, well, first line is Cellcept, and then I, consider rituximab. And then there's guidelines that kind of support some of these medicines. But the amount of asterisks that we would need to fully kind of encapsulate like all of the ways that we think about it in order to kind of make a real kind of guideline for how it actually is would be a lot of pages. And we asked doctors like what other condition, like what are the manifestations of scleroderma impact how you treat it, and myositis was one of the ones that impacts it a lot. So we think about everything at once, but a lot of these guidelines, like Dr. Bernstein presented, the interstitial lung disease guidelines that said, these are the medicines you use, and then there's, skin treatment, and these are the medicines, but we kind of put it all together when we're, talking about a specific plan.
I'll make one other point. So like in terms of that, overlap that we can sometimes see with scleroderma and myositis. In general, we see overlap a lot. So scleroderma can overlap with also some Sjogren's, dry eye, dry mouth, and sometimes there's a blood test that's associated with it. Scleroderma can overlap with rheumatoid arthritis. It can, and all kinds of like other conditions as well. Lupus, we can see overlap with. I like to just make that point for the group because sometimes I'll have a conversation with my patients where they're like, I don't know, maybe feel like they're the only one in the world that has like this and have that kind of like, I feel a little like lonely. But you can really see overlap with scleroderma and other rheumatologic conditions, not infrequently. And that's true in rheumatology for these other conditions too. We can see overlap a lot. And it's something that I think rheumatologists in general are very open to and, think about.
I guess I'll ask another question. Out in the world today, you see a lot about nutrition, diet, and there's lots of stuff on autoimmune with gut health. I wanted to ask you guys a question about, do you think gut health, does it help? Or, I mean, of course, good nutrition does help, but does it have any impact on scleroderma?
So I'll take that one. I'll try. So first of all, nutrition is very important for everyone, right? So, and I think it is really important for us to think about that. But there's probably not one approach to good nutrition. And I think sometimes when, I don't know, we're reading online or things like that, it can kind of seem like you have to do this XYZ, and I don't think that's really true. In terms of general approaches to good nutrition, I think looking at Mediterranean diet or like plant-based or plant-forward diets probably do really offer a lot for general health and for people with autoimmune conditions. Does it have to be perfect? Probably not, but a lot of folks feel better when they're able to kind of follow those nutrition plans. There are a lot of special circumstances that come up in scleroderma because of GI disease that would take a little bit of fine tuning with those kinds of diet plans, right? Because reflux is a big problem. A lot of these kinds of healthy foods will flare up reflux, like tomatoes and stuff like that. Certain foods can increase like gas in the intestine. So for folks who have small intestine bacterial overgrowth, they are frequently recommended to go on a low FODMAP diet. I feel like the people who know what I'm talking about know what I'm talking about here. And that includes like lots of healthy foods wind up being restricted in that kind of diet, but it's needed. So it gets a little bit more complicated. Some folks, do have trouble tolerating a lot of things or maybe having issues with weight loss too. So it is like still have to get all those calories and so I think in scleroderma we do the best we can, and we have to kind of fine tune a little bit. And I also so nutrition's very important. But sometimes I'll see folks kind of internalize that, like maybe they can control everything through their diet, or if they can just do it well enough, it would make everything better. And I don't think that we see that. I think it does have an impact, but it's not like you can control everything if you get it just right. So I try to be sensitive about that.
Anti-inflammatory diet?
Right, yeah, that's what, So there are different kinds of diets that you'll see that are anti-inflammatory. There's an anti-inflammatory protocol that you can read about. It's quite restrictive. I don't know that that's necessary, so I use the term plant-based, and then, but that's sort of what it's getting at. Does it have to be that restrictive? I'm not sure. I think the Mediterranean diet sort of offers a little bit of a less restrictive version that is quite healthy.
And I'm just going to very parenthetically add, I think sometimes we get ahead of ourselves with that, though. People want to be able to control their disease and their environment, and the converse comes up that people feel that I did this to myself, or I'd be doing better if I ate differently. There's actually very, 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 very little, if any, evidence in scleroderma specifically of diet affecting outcomes, I would say. So I tend to be a little bit more permissive if somebody's interested and oriented that way. I encourage it because it's good to feel like you're in control of your health. But I feel that some people come in and they're just waiting for their husband or wife to leave the room so they could say, can't I just have pasta again? Or can't I have this? Or can't I have that again? And so I'm just a little guarded about it until we get better evidence. But
Yeah. And I would just add, sometimes there's the, is this going to hurt me? And then is it safe? And then is this effective? And so sometimes when people are very motivated, they want to add turmeric or increase tart cherries or other things like that. If it's safe and it's not making things worse, I can be encouraging, but I usually suggest it to be thought of similarly as any other intervention that we're doing. So if we're starting a medicine and it doesn't work, maybe we up the dose a little, but then we would stop it and try something else. And sometimes what I can sometimes see in the sort of diet is a lot of doubling down, removing more things until people feel like they don't have a lot of good foods left. And so I always encourage people to kind of think of it like you would with any other intervention, documenting sort of how you're feeling, assessing if it's working, and if it's not, switching gears. And, because, food is so much part of our lives, and there's so many good things out there that we can enjoy. So.
My last question, I promise. Is there any studies done for for Raynaud's in different climates, like say a person that lives in Florida that has a more warmer climate all year round, like how it affects them versus us here when seasons change?
I mean, we definitely see lower symptoms in warmer climates. I mean, for folks who, and then the flip side of it is I've definitely had patients like move to Florida and then get disappointed because even if it's hot outside, every place is like really air conditioned. So they find, some of those same problems. So,
Yeah, no, but it's also very important when we're studying it. Like we're a site for a digital ulcer observational study, and they're like, we got to get it going before the beginning of this winter because this is the time period to really kind of study this type of thing, and that would be sort of different in a Florida research setting.
Okay. Thank you all so much.